Hi, everybody. Welcome to our session on Saturday. Finally, after a long and great week of sessions in the Pulmonary Fibrosis Foundation Summit, it's time for our final day. And we're going to be talking today for the next 4 hours about community pulmonologists, intended for community pulmonologists and ILD Fellows, for just sort of a general update on pulmonary fibrosis. So glad to have you all here and welcome all. This is going to be an interactive day. There's going to be speakers and Q&A, and I hope that you'll be putting lots of questions in the chat for us to have a very interesting discussion. A little bit of housekeeping stuff. My name is Dan Dilling. I work at Loyola University Chicago, along with Mary Streck at the University of Chicago and Roddy Tomich that you're going to meet in a second. We were happy to co-chair the conference for you this week. We're going to be hearing sessions in 4 different blocks today. For the first part, we're going to be hearing some things about connective tissue disease and special age population kind of workup of ILD. We'll have a short break, and then again, we'll have a couple of sessions this time around COVID-19. I think those are going to be really intriguing. We'll have a little bit of a longer break, and then we'll have a group of sessions about diagnosis. So these are going to be about cryobiopsy, a great radiology session, and a session on genomic classifiers. We'll have one more short break and then come back for what I hope is going to be your favorite part of the day, a multidisciplinary discussion group where we're going to be discussing interesting cases with the interactive discussion, meant to mimic what we all do in our ILD clinics when we're seeing new patients that are going through their workup testing to make a consensus diagnosis. So with all of that said, please sit back, find a comfortable chair, a big screen maybe, enjoy all the sessions, and bring us all your great questions. And with that, I'll turn it over to my partner, Roddy.
Good afternoon, everybody. It's a pleasure and honor to have a chance to chair this session. I'm coming from Northwestern University here in Chicago. I'm the co-director of Interstitial Lung Disease Program and director of the Lung Transplant Program here at Northwestern. I'm privileged to have opportunity to chair the session today for 2 distinguished ILD physicians. First talk is from Dr. Volkman. It's about connective tissue diseases associated interstitial lung disease. Dr. Volkman is director of UCLA Scleroderma program and founder and co-director of UCLA Connective Tissue Disease related interstitial lung disease program. After Dr. Volkman talk, we have a great talk from Dr. Witt. She's going to talk about diagnosing of ILD in the special age population. And Dr. Witt is pulmonologist and geriatrician in UCSF, and she's a clinical educator and current geriatric academic career awardee from Health Resources and Service Administration. So without further ado, we'll open the floor to the first presentation of Dr. Volkman. Thank you very much, everybody, and enjoy the presentations.
Hi, my name is Elizabeth Volkman, and I'm the director of the UCLA Scleroderma program and the co-director of the UCLA CTD ILD program. And I'm delighted to be here today to speak with you about systemic sclerosis-related interstitial lung disease. These are my disclosures. So the objectives of this talk are to review the features of systemic sclerosis-related interstitial lung disease, or SSc-ILD. We'll also discuss how you screen and diagnose SSc-ILD, and finally, we'll review some treatment options for this condition. So systemic sclerosis is a relatively rare autoimmune connective tissue disease with the prevalence in the US shown here. This is a condition that disproportionately affects more females than males, and it is also more prevalent in African Americans. When we think about the age of onset of this condition, it typically occurs between 30 to 60 years. But obviously, there are some patients that can get it at a much younger age and also at a more advanced age too. This is a multi-system disease, meaning that it affects different organ systems. So the majority of patients will have involvement of their skin. We call this cutaneous sclerosis. Also, many patients will have musculoskeletal involvement, such as arthritis and joint contractures. And then after this, the next most common organ systems are the GI tract, followed by the lungs, then the kidneys, and then the heart. In terms of the lung disease, this affects about 65% of patients. So if you look at a consecutive group of patients with systemic sclerosis and you screen them with HRCT to look for the presence of ILD, the majority, or about 65%, will have these abnormalities. And this is the leading cause of death in these patients, and it also contributes to increased hospital admissions, outpatient visits, as well as days missed work. The interstitial lung disease occurs early in the course of systemic sclerosis. So in this slide here, we're looking at a graph of time. So if we look at over the course of the first 5 years, whether a patient has diffuse or limited skin disease, the interstitial lung disease typically occurs within the first couple of years after the diagnosis of the disease is made. So this is something that we really want to screen for early on so that we don't wait too long to diagnose it and ultimately treat this condition. How do we evaluate these patients? So sometimes when patients first develop interstitial lung disease, they can have very mild symptoms, and they may include just feeling more fatigued when they're exercising. This can eventually progress to feeling short of breath or dyspneic on exertion. The second most common symptoms after shortness of breath is actually a chronic cough, and this can either be a dry or a wet cough. But it's also important to keep in mind that many of these patients can be asymptomatic when they first present to you. And so it's important to ask very probing questions such as, have you modified your lifestyle in any way? Are you doing activities now, and how are they done now compared to how they were done 6 months ago? But keep in mind, again, many of these patients will be asymptomatic. We evaluate these patients using a high-resolution chest CT. And the reason why we do this is actually the most sensitive way to detect early interstitial lung disease. So pulmonary function testing can be done, and it's very important to do to measure the degree of restriction these patients have. But early in the course of interstitial lung disease, the PFTs can be normal. So you cannot just rely on PFTs to screen for the presence of ILD. We also have patients undergo a 6-minute walk test, and then we also order specific blood tests. These are called serologies. And these give us information about what the future may be for the patients who have systemic sclerosis, their likelihood of developing interstitial lung disease or developing severe interstitial lung disease. This is an example of axial and coronal views on HRCT of the chest of a patient. And this patient has very early interstitial lung disease secondary to systemic sclerosis. And what you can see here is that in the bilateral lower lobes, there is reticulation as well as some ground glass opacity. And this is consistent with what we see in NSIP pattern of interstitial lung disease. This is the most common pattern that we see on HRCT of the chest of patients with SSc-ILD. And on pulmonary function testing, I mentioned we do this at baseline, and we also do this to monitor progression of the disease. So we're looking for restrictive physiology, and this is typically characterized by a decrease in the TLC, a decrease in the FVC, and a decrease in the DLCO. And typically the ratio, the FEV1 to FVC ratio, is normal, or it can even be elevated. So early on in the course of interstitial lung disease, usually the first parameter to decline is the DLCO. And then as the disease evolves or progresses, the DLCO and the FVC decline. Later in the course of the ILD, what we can sometimes see is a further decline in the DLCO relative to the FVC. And then when this happens, we have to think about the development of pulmonary hypertension too. I mentioned to you that the autoantibodies can be very helpful in this disease for providing prognostic information. So the first one's listed here, the SCL70. Another name for this is anti-topoisomerase 1. And all of these ones listed here are associated with having more progressive ILD. So they're very helpful to measure because if you see this antibody in a patient, you will know that there is a high likelihood this patient will have progressive or worsening of their interstitial lung disease. This contrasts with something like the centromere antibody. When patients have a centromere antibody, they're actually less likely to develop interstitial lung disease, or if they do develop it, it's typically more mild. But these patients have a higher risk of developing pulmonary hypertension. And then the last one listed here is the RNA polymerase 3. This one is associated with having renal crisis. It's also associated with having a more diffuse skin disease. And again, these patients can develop interstitial lung disease, but it's usually more mild and not a progressive fibrosing phenotype. So now we'll move into treatment because I think this is a very exciting area of scleroderma right now. There's a lot of interest in developing new therapies for scleroderma, and we actually, for the first time ever, have a lot of options to offer our patients and can really personalize their treatment. So I'll take you through a little bit of the history of the medications that we use presently for scleroderma and some of the evidence for why we use them. So the first one is cyclophosphamide, and this was really the first large randomized controlled trial that was done in SSc-ILD, and it was comparing 12 months of oral cyclophosphamide with 12 months of placebo and a multi-center randomized controlled trial done at 13 different sites in the United States. And what you can see here is the change from baseline in the FVC. So a positive change indicates improvement and a negative change indicates worsening. And what you can see is about half of the patients who were randomized to cyclophosphamide had improvement compared to only about a quarter of the patients who had placebo. In addition, the treatment with cyclophosphamide was also associated with improvements in health-related quality of life, which is what is listed here, as well as their MRSS or their skin score. But what was interesting was that in this study, patients were followed for an additional year off of therapy. And what they found was that after a year off therapy, the FVC basically went back to baseline, and there was no difference between treatment arm and placebo. So what this taught us was that really patients need to be treated for more than 1 year with immunosuppression. But cyclophosphamide is a somewhat toxic drug, and it's not really safe to do for more than about a year. So this led to the rationale for the second scleroderma lung study. And in this study compared 2 years of mycophenolate versus 1 year of cyclophosphamide followed by 1 year of placebo. And again, the rationale was that mycophenolate would be safer to do long term. And what this study found was that actually both of these treatments led to a significant improvement in the forced vital capacity over the course of 2 years with no between treatment arm differences. And then again, you can see here that same figure that we looked at before, the change in the FVC, and you can see that in the majority of the patients, so 65% and 72% of the cyclophosphamide and mycophenolate participants respectively had an improvement in their FVC. In addition, both of these treatments led to improvements in self-reported dyspnea, and we used the transitional dyspnea index in this study to assess dyspnea, and an improvement is a positive change. But where these two treatments really diverged is in their safety and tolerability. So this graph here looks at the time to premature withdrawal from study drug or treatment failure, and you can see that there was a significant difference, meaning the cyclophosphamide participants had more withdrawals, and in addition, they also had more deaths in this study. So this really led to mycophenolate being used as sort of the first-line treatment for patients with SSc-ILD. But we have some other exciting options, and one option is something called rituximab, and this is a biologic medication that's already approved for other autoimmune diseases such as rheumatoid arthritis. There hasn't been any large randomized controlled trials done using Rituxan, But there has been some observational studies, which is what is demonstrated in the graph here, where they've looked at patients who have failed other treatments such as mycophenolate, and then they've put them on rituximab and compared these patients to match controls, and it seems like there's a benefit of Rituxan. There also has been a small randomized controlled trial looking at Rituxan that also indicated that this might be effective for patients who fail other therapies. And there's currently an ongoing clinical trial in the UK looking at cyclophosphamide versus rituximab for patients with connective tissue disease related ILD, and many of the patients in the study have systemic sclerosis. Another option is nintedanib, and this was recently FDA approved for the treatment of SSc-ILD. And you can see in this figure here that in patients randomized to nintedanib, they had less of a decline of their FVC over the course of 1 year compared with placebo. It's important to note, though, that in this study, about half of the patients were on background mycophenolate therapy. They weren't randomized to it. It was just that their provider had them on mycophenolate therapy, and they had to have been on a stable dose for at least 6 months prior to enrollment in this study. And so on the left, you can see those patients taking mycophenolate at baseline, and on the right, you can see the patients that weren't. And what's, I think, striking about this figure is that the patients taking mycophenolate at baseline overall did better than those who hadn't been on it. And the patients who were on the combination actually did the best of all in terms of their decline in the FVC. Another option, also recently FDA approved for the treatment of SSc-ILD, is a medication called tocilizumab. This is a similar type of biologic medication that's also approved for other autoimmune diseases such as rheumatoid arthritis. And this was a study that was designed primarily to look at skin disease and scleroderma. So it enrolled patients who had relatively early diffuse systemic sclerosis with evidence of active inflammation in their blood. But what they noticed was that the forced vital capacity was a key secondary endpoint for this study. And what they found was that the patients who were randomized to the treatment arm actually had a better course of their FVC. So the left graph is looking at all of the patients in the study. And then the right graph is looking just at those patients who had interstitial lung disease. And you can see that the placebo arm had a pretty significant decline in their FVC over the course of the study. This study did not include patients on background therapy. It was a true placebo study. And then another option that we have, and we typically do this after we've tried some medications in patients, is stem cell transplant. And this is typically done at select centers through the country that have experience with doing stem cell transplant. And there have been 2 major trials that have been done looking at this intervention for patients with SSc-ILD. The ASTIS trial, which was a European study, and then the SCOT trial, which was a US study. And both of these studies compared the transplant to getting treatment with cyclophosphamide. And long-term, there was a survival benefit, and the majority of patients in both of these studies had interstitial lung disease. So again, the stem cell transplant is really an option for patients who have relatively early diffuse skin disease with some internal organ involvement, and it has to be performed at an experienced transplant center because it is a somewhat risky intervention. So when we think about how we treat these patients, I think one of the first decisions that has to be made is when to start therapy. So I would consider starting therapy in a patient with a new SSc diagnosis, especially if it's been less than 5 years since the diagnosis was made, because we know from studies that this is the time period where the disease is most likely to progress and where interventions can really have an impact. But regardless of disease duration, if the patient has interstitial lung disease and they're showing signs of progression, so if they're losing lung function on PFTs, if they have radiographic progression of ILD, if they feel more short of breath, this would be another indication to treat these patients. And this is just an example of one patient who had ILD progression. So on the left panel, you can see an example of very mild early interstitial lung disease. And this patient actually opted to not start therapy But you can see that over the course of 6 and then to 12 months, there was significant radiographic progression of interstitial lung disease, as well as worsening of the pulmonary function testing. So this is a good example of intervening to prevent the progression of ILD early on. And in terms of how we think about the treatment algorithm, so again, I think that mycophenolate is really considered the first-line agent for this condition. But if a patient has progression of interstitial lung disease despite treatment with mycophenolate, there's a few options to consider. So rituximab is one option, and this might be something to consider in a patient who has overlap inflammatory arthritis, because we know that rituximab works for arthritis. Nintedanib, as we saw, can be safely combined even with mycophenolate, and this is something that might be advantageous for a person where you wouldn't want to escalate their immune suppression, but you wanted to just add on an antifibrotic to prevent the further loss of lung function. Tocilizumab, again, this is the latest agent to be approved. This might be something you'd consider in a patient with early diffuse skin disease with active inflammation. And then finally, the stem cell transplant is really an option for patients that are rapidly progressing despite medical management, who are going to be able to be seen at an experienced transplant center. So to summarize, interstitial lung disease is the leading cause of death in SSC, and all patients with SSC should be screened for the presence of ILD with a high-resolution chest CT. Treatment should be considered in patients who have relatively early disease, so less than 5 years, but actually they can be considered in any patient of any disease duration if they're showing signs of ILD progression. Mycophenolate is the first-line treatment for most patients, but we have a number of other options, which I've listed here, including rituximab, nintedanib, and tocilizumab, and then the stem cell transplant for select patients. And really, it's important to personalize the care. So now that we have options for patients, it's helpful to apply a multidisciplinary approach for caring for these patients. So working with pulmonologists, rheumatologists, radiologists can be very helpful in tailoring the treatment options for patients with SSC ILD. And I'd like to thank you for your time today.
Hi, my name is Leah Witt. I'm an assistant professor at UCSF in Geriatrics and Pulmonary Medicine. And today I'll be talking to you about the workup and care of older adults with interstitial lung disease. So my goals for you at the end of this session are to explore the workup and management considerations in older adults with interstitial lung disease. And I hope by the end you learn to think like a little G geriatrician in taking care of older adults with interstitial lung disease. So by that I mean how to assess their function, frailty, and how to review their treatment preferences to achieve goal concordant care. So I'd like to start with a case. This is Mr. Johnson. Mr. Johnson's an 82-year-old man with newly diagnosed ILD, and you're seeing him in the ILD clinic. Initially, he presented with shortness of breath and dry cough 6 months ago. His forced vital capacity is 40% of predicted. It's dropped a bit in the last year. It was 58% of predicted last year. His oxygen saturation is 85% on Romair, and he was recently prescribed oxygen by his primary care doctor. His MMRC is 4, that means he's breathless when dressing. And his CT scan shows probable UIP, probable usual interstitial pneumonia. So he's got traction bronchiectasis, basilar reticulation, but no honeycombing. His traditional medical history, and later we'll talk about what his geriatric history is, but his traditional history is that he's got hypertension, coronary artery disease, diabetes, anxiety, COPD, and he's on standard medications for these medical conditions. So I'd like to start by giving you a little bit of background about the prevalence of interstitial lung disease in older adults. So 24% of ILD patients are over 70. That's from a study by Patterson and colleagues in 2017. And though we think of IPF as often as the chief ILD of the elderly, there are actually studies that show that's not totally true. IPF is common in terms of interstitial lung diseases in the elderly, but many patients have unclassifiable ILD, and there is a small group with CTD, ILD, and hypersensitivity pneumonitis, just like other age groups. IPF and aging do go hand in hand. So the prevalence of IPF increases with age, and age, in fact, is a strong clinical predictor of IPF. You might know that in familial IPF, short telomeres have been associated with the IPF cause. And in fact, short telomeres also happen with aging. So that is hypothesized to be part of the pathogenesis in some IPF. Mean age in national IPF registries and clinical trial cohorts are actually 66 to 73 years, so in that geriatric or older adult population. So diagnosis of ILD, as you all know, is very complex. It requires clinical assessment, pulmonary function tests, high-resolution CT scan. It requires serology to rule out connective tissue disease. And then we bring all of that to an interdisciplinary, multidisciplinary committee in our interstitial lung disease clinics, where we talk between pulmonologists and radiologists and pathologists about what the likely diagnosis is, all to come out with a likely ILD diagnosis. And thanks to Helen Jo for this slide that she put together at a previous presentation. And sometimes the diagnosis also requires lung biopsy. So I wanted to take a detour for a second to talk about what a lung biopsy for ILD in an older adult might look like, what sort of risks you might be thinking about. So surgical lung biopsy overall is associated with about a 10 to 15% risk of complications. Low overall in-hospital mortality, but actually elderly patients have higher risk due to frailty in some cases and presence of comorbidities. And actually, in a retrospective analysis of in-hospital mortality, there was a steadily increasing risk with age. So let's step back and think about Mr. Johnson. I want you to think about how you would consider his ILD in the context of his overall health. And I gave you his traditional medical history, but let's talk about his geriatric medical history. What do we need to know to guide treatment decisions? And how do we discuss diagnosis and prognosis with Mr. Johnson? So here's additional history, but with a geriatric lens. And by that, I mean focus on function and goals of quality of life, what brings someone joy, and sort of the bigger picture. So Mr. Johnson lives with his wife in a 3-story house. He uses a walker to ambulate. He has a 20-pack year smoking history, and he needs help with bathing and dressing because he's so breathless. He needs assistance with medication management, and that's because he's been more forgetful. He feels very anxious. He says, I get breathlessness attacks. I feel like I'm going to die. I spend most of the day in my chair to avoid that feeling. He wants to focus on quality of life and not necessarily longevity. He's willing to undergo some treatments, but he doesn't want to take lots of pills or medications. So let's start with sharing diagnosis and prognosis. It's important to remember that delivering a diagnosis like interstitial lung disease, like IPF, or many of the other diagnoses we deliver, is serious and usually bad news that requires skill to break to a patient and a family. This is one of my favorite ways to consider how to break bad news to a patient. It's called spikes. So first setting, think about the environment, participants, distractions, make sure all the key players are there for Mr. Johnson. It might be him and his wife, maybe a child who wants to join by phone or Zoom. Think about perception. So ask, tell, ask. You want to ask what Mr. Johnson and his family knows before you tell them. And then you want to deliver a headline of information, not a 30-minute monologue. You want to deliver a headline and then ask if they understood what you meant, what questions they have. Invitation is very important. Obtain information from the patient and the family about what they want to know. If they want to know prognosis, for example, you could say something like, Some patients I see want to know what the future holds, and some people would rather take things day by day. Which sort of person are you? K is knowledge, so share information with the family and patient. E is address emotions. That is extremely important. So if Mr. Johnson is tearful, if his wife seems angry, if you don't address those emotions in the room, I can guarantee you that they won't hear any of the great K knowledge that you're sharing. So it's really important to say things like, I can see this is really difficult news. I noticed that you're upset. Can you tell me more about that? And then S is summarize and strategize. Talk to patients and families about what to expect and disease progression. So shared decision-making for Mr. Johnson would look like, based on your age, this is the knowledge part, based on your age and probable UIP pattern on CT scan. By the way, you'll have to explain what UIP pattern means. But we think IPF, idiopathic pulmonary fibrosis, is the most likely diagnosis. And then I think some explanation about what IPF means is also key here. We think that the risk of a biopsy is greater than the expected benefits. I would like to talk to you about what the future holds and how we can help you manage this disease. I would keep these two headlines, and as I said before, ask about what Mr. Johnson and his family understand before proceeding with a download of information. So the next step is to talk about treatment. So for Mr. Johnson, we think he has IPF, so we want to talk to him about antifibrotics. It's really important in the older adult to assess their values and preferences. Where does he fall on the spectrum? Is he someone who prefers to take medications for prevention, even if the benefits are mainly in the future? Does he prefer to take medications once symptoms become a prominent feature or the quality of life is impacted? And how important is improving quality of life versus length of life? And for older adults, I think it's important also to keep in mind and share with the patient that the antifibrotic medications haven't been consistently shown to improve quality of life or respiratory symptoms. So I share that with them. I don't think this is going to help you feel better, but the benefit is that, the antifibrotic medications will slow down the progression. And there are some post-hoc analyses. You can share this with them. For patients who have participated in clinical trials that both may decrease mortality. And then I think talking about the side effects that they're likely to experience is very important. And then another element is the cost, and discuss that cost may be a barrier, and we'll work with you on that. But all of these pieces come to play when you're deciding if you want to take an antifibrotic. Just to dive in a little bit deeper on the antifibrotics, pirfenidone, there's been some review of different age groups from the pooled clinical trials that have shown that unfortunately older adults, patients over 80, do experience more adverse drug reactions resulting in stopping the drug or dose modification or interruption. So this is a great slide from Dr. Rekovich at University of Chicago. She suggests, and I agree with her, that prescribing the 267 milligram tablet is important because then the dose can be modified more quickly. And for nintedanib, same thing. We usually start with the 150 milligram dose, but we have a low threshold. I have a low threshold to decrease to 100 milligrams if the patient is intolerant or having side effects. It's also extremely important to address non-pharmacologic, non-medication ways to help someone with their symptoms from IPF. And there are many things you can do. So they're listed here, including pulmonary rehab, breathlessness interventions, breathing exercises, so they can be equipped with self-management techniques, mindfulness, stress reduction techniques, also things like support groups and learning from others about how they're managing their symptoms. I also want to empower you to believe strongly and share with patients that symptom management and palliative care is treatment. Sometimes people have the perspective that if they're being referred to symptom management or palliative care services, that we're giving up or this is sort of the end of the road here. That's not the case at all. I think robust, high quality interstitial lung disease care actually does involve careful symptom management. So it's really imperative that we assess goals, fears, grief that people may be having about trips that they wished they could take that they no longer feel up to taking, travel, prognosis, and kind of grappling with what the rest of their life might look like. Caregiver distress is super important to address. Advanced care planning is important. And using the resources that you have at your disposal to benefit the patient, like referring for support groups, for palliative care, and for social work. So the takeaways that I want to leave you with is that IPF prevalence, it does increase with age, and age is a strong clinical predictor of IPF, including in situations with probable but not definite UIP. Discussing a new diagnosis of ILD can mean breaking bad news. So use that spikes mnemonic to deliver this information thoughtfully. Talk about prognosis after asking for permission to give that information, and deliver in little pieces over the course of the relationship. It's important to document that conversation along with advanced care planning. Older adults might experience more adverse reactions to antifibrotic medication, so shared decision-making about antifibrotics is important, and frequently checking in about side effects. Palliative care and symptom management is treatment and should go hand in hand with discussions about antifibrotics. And again, I want you to become a little G geriatrician, and that means thinking about ILD and thinking about their chronic lung disease in the context of their overall health, and engage in shared decision-making to discuss diagnostic and treatment planning. Thank you very much.
Thank you, everybody, for the great presentations to Dr. Walkman and Dr. Witt. Unfortunately, Dr. Walkman was not able to be with us today, so Dr. Dilling and me will answer the question for Dr. Walkman. So I will open the floor to the questions, and we can go ahead.
Maybe we'll start with a question for Dr. Witt. So at what point in the visit course, is it first visit, second visit, or later, do you discuss prognosis with patients? So, and who needs to be there? In other words, especially in these times of COVID and all, like, they can't have all their family members there with her. And how do you handle that situation? Is almost a separate question, but and maybe even what tools do you use for assessing prognosis?
That is such a good question. Well, ironically, in some ways, the pandemic has made us more comfortable with virtual tools to sort of bring in more family members from across the country to listen into visits and conversations like this. So I think that is one asset, but I'll just say that sometimes the first visit is the right time and place to discuss prognosis. But I would say that's not the typical case, because usually there's so much information to gather and history. People have so many questions. You're sort of collecting information, and then the next step is the multidisciplinary conference. So in rare circumstances where someone maybe lives really far away, or their ILD is very severe, I want to make a point to talk about it on the first visit, but I usually prefer to discuss the prognosis on the second visit. And I think best practice, if it works for you, is to have really short-term follow-up right after the multidisciplinary meeting. If you could schedule a visit in a week, in 2 weeks, that would be ideal, because usually that first visit is not enough time to go over everything. And maybe there's still some diagnostic uncertainty. So you can review diagnosis, you'll have built some relationship and rapport, and can talk about prognosis then. And I think prognosis is not a static conversation. It's an evolving, iterative conversation with each subsequent visit, a new piece of information and hospitalization, where you sort of reframe what's going on, maybe evolving goals and preferences based on how someone's responding to a antifibrotic medication or immunosuppressing agent. But I do think if possible and if someone is willing, it's really helpful to have multiple people participating in this conversation, because multiple ears hearing the information and taking down notes and asking questions is helpful. And then you can definitely involve people virtually by Zoom, even if you're seeing your patient, right in the room with you, which is really useful. The other thing that I've found to be super helpful, but also you have to be really thoughtful about it, is open notes. At our institution, and I think this is a federal law, our notes are shared with our patients, which is actually great, because I think that empowers people to be able to have the full spectrum of information available to them. But you should be cautious that, if your first visit note says things about prognosis that you didn't share with your patient, I think that could potentially be detrimental to your relationship. So be transparent with what you're saying verbally and what you're writing as well. I think that's really important.
It's an interesting thought. And I think we're all getting used to open notes in good and bad ways, that, there's some stumbling blocks and learning curves and watchouts that we're all kind of catching. And I think your point right there, that sometimes I historically have written some things in my notes that are meant for me for the next visit to sort of be triggers for, carrying on good conversations. But you're right, there's some traps that you can set for yourself these days with that. So we have to be careful. And I totally would share your approach to this and say this, that a lot of times the patients come to us at the ILD center, having been referred, thinking, and understandably thinking, that they're coming to get all the answers that day on that first visit. And yes, you're right, there's a lot of information to collect. There's a lot of history to be taken. There's a lot of rapport to be made on that first visit. But then at the end, you have to kind of say, well, I've collected all this information. There's more that I want to get. I got to get that CT scan. We got to get those biopsies sent over. We're getting these serologies that, we still need to do. And we're going to be talking with our colleagues in the multidisciplinary discussion. And I'm sorry I don't have all the answers to your questions today, but I promise that we'll have more to talk about the next time. But we still have to warn them that even the next time, we might not even have everything wrapped up, because that might be a discussion about getting a biopsy or something. So I share that approach, and it's wise.
I think a great point from both of you. It's really hard when you see the first patient to kind of predict trajectory where they're going to. So I think that longitudinal relationship really helps, and multiple visits and multiple tests where you can kind of see where your patients are going. And really, unfortunately, we don't have great tools to predict natural history of IPF or some other interstitial lung diseases. I think the great points. I will start with one question for Dr. Volkman that Dr. Dillingham maybe can try to answer. When would you consider combining mycophenolate with nintedanib for the treatment of Scleroderma associated ILD?
And by the way, we should invite Dr. Witt to interject here as well, sure. Because we all struggle with these same questions, I'm sure. So this is an interesting one, because I think we're all used to using mycophenolate because it has had this indication longer than nintedanib, although we've been using nintedanib for a long time too in a different population of folks with IPF. So with that said, I think mycophenolate is more easily tolerated on average than nintedanib, and we have a little bit of a longer track record of evidence with that. And so I tend to use that as my first line therapy. And I almost never would start both drugs at the same time, trying not to mix side effects or overwhelm the patient with pill burden and questions about which side effect is being caused by which drug and these sorts of things. So my approach is mycophenolate as a first line, and especially if there's progression, or maybe just at a subsequent visit introducing nintedanib. I think my habits and my approach to this are in development still, given that this is still a pretty recent indication, and sort of practice change?
That's my practice too. And I completely agree that you have to be really cautious about how you introduce these medications, because you don't want the cumulative GI side effects to turn your patient away from completely, like, discarding both of those medications. So you have to be really careful and closely have the GI side effects from mycophenolate managed before you introduce something else.
I agree with both of you. It's mycophenolate is probably the first line, and the reason for trigger for me, at least, to add OFA will be progression of disease and more fibrotic progressive phenotype in these patients with scleroderma. One thing that is surprising for me, based on the clinical trial, that actually addition of the OFA or mycophenolate in scleroderma patients who already have a lot of GI issues didn't cause so much more increase in the side effects. But that's a clinical trial, and we'll have to see how the clinical practice will follow that.
Mm-hmm. Now, Dr. Tomic, I know that at your center there's a well-established stem cell program combined with the scleroderma program with some folks that have been there a long time. And there's a question for Dr. Volkman that I think maybe I'll send to you first here. But at what point does a stem cell transplant become sort of part of the game plan for somebody who's got scleroderma interstitial lung disease? Like, how far down the path of introducing other medicines, at what point do you get to stem cell?
Yeah, it's really selected cases who have probably rapid progression and not responding very well on the medications. It's I think still pretty much unclear, in clinical practice when to use the stem cell, because when you look at the clinical trial, particularly the American one, it was actually used to in patients with moderate disease, and you're committing them to lifelong immunosuppression and complication of the stem cells. So it's still not completely clear, but we use it for the patients with probably rapidly progressing lung disease and not responding on the usual medication therapy for the ILD scleroderma.
So it would be someone who's gotten and either not responded or not tolerated mycophenolate and nintedanib and maybe rituximab, and we're sort of getting into last line therapies, I think. Huh?
Yeah, I think we'll use it in that type of circumstances. I don't know, Dr. Witt, how is it at your center?
That I'm definitely not an expert in, and I actually haven't taken care of any patients who've had stem cell transplants for this indication.
Yeah, we can. There is some question from the audience that maybe we can try to answer. First question: why do I get the chest pain in my heart when my oxygen is low? This happens in the patients who have, unfortunately, pulmonary hypertension. With hypoxia, the pulmonary hypertension tend to get worse, and that's why the chest pain can develop. But anybody who has a chest pain should definitely rule out, by my opinion, cardiac causes of the chest pain and make sure that we are dealing with the pulmonary issues. I don't know what other panelists think about this question.
Yeah, I think I'd be careful about trying to say anything too specific to somebody with such limited information, but I think anytime chest pain comes into the conversation, it certainly needs a careful evaluation, either in the short term with your doctor or even visiting an emergency room. Chest pain's an alarming feature of anything, depending on the bigger context of what's going on. Dr. Witt, what do you think about antifibrotics for the population of patients for whom it's indicated, IPF or maybe progressive fibrosis of other sorts? Do you think especially as a geriatrician with maybe a collection of more older patients than the average pulmonologist, are there some that don't get it, or is it try it on everyone and take it away from those that don't tolerate it? Like, what's your approach?
Yeah, I think that we have to be careful about both overtreatment and undertreatment in the geriatric population. So I think that my personal practice is to talk about antifibrotics with every patient who who otherwise would qualify, just thinking about their disease. I talk to them about antifibrotics, and then I discuss with them their goals and preferences. As I mentioned, what kind of patient are you? Do you like to take preventive medications? Do you like to only take medications that will improve your symptoms, so that I can expectation set? And then sort of talking about sort of pulling together all that information, I might give my opinion. So based on what I know about you, your other medical conditions, I think this would benefit you, or I think that you might be too frail to tolerate this medication. But I do talk about it with everybody, and it's always in the back of my mind that, just because someone is 85, 90, 95, it's, I think, incumbent on us to just have this discussion with them, and that undertreatment is actually ageism as well, and like making decisions. Also, sort of when we're discussing in multidisciplinary committee conference, it's important to, as the person presenting your patient, you know them best, the clinical context and their history and their values. So you'll have to take that into context, irregardless of the age. Age is actually just a number, and multi-morbid older adults can be in their 60s, and we can have relatively healthy and older adults in their 80s who could probably tolerate an antifibrotic well. And I have several in their 80s who are tolerating it just fine.
Yeah, I think that's a great point.
So
go ahead, Dan. Yeah, I will just say it's a great point. I think we should put everything together in the context for this older population and treat them as indicated, and following their values and so on. I think we are running a little bit out of the time, so I just want to thank you for everybody for the great questions. And I think the break is coming after this session, and we'll see you everybody in the next session.
Thank you.
see you back soon.
Sure. Thank you, everybody.
My name is Anna Podolanchuk, and today I will discuss the prognosis, vaccination, and prevention of COVID-19 in patients with ILD. The COVID-19 pandemic started in December 2019 and is ongoing. It has affected every single country around the world. As of September 27th, there have been more than 230 million cases of SARS-CoV-2 infection, which is the virus that causes COVID-19. This number is likely a significant underestimation of the true number of infections. There have been more than 4.7 million deaths worldwide due to COVID-19. The United States has had the largest number of COVID-19 cases and deaths. Importantly, there have been more than 6 billion doses of COVID-19 vaccines administered worldwide. Patients with interstitial lung disease have an increased risk of morbidity and mortality due to COVID-19. Several studies have reported mortality rates for patients with ILD diagnosed with COVID-19 that range from 19% to 49%. Most of these were in hospitalized patients, and these studies were done early on in the pandemic when there was limited access to testing and evidence-based treatment for COVID-19. Still, patients with ILD infected with COVID often require hospitalizations and are at high risk for death. More recently, there was a population cohort study that reviewed records from general medical practices in England. In this way, they were able to capture all patients with ILD and other respiratory conditions residing in these communities. They looked at rates of hospitalization, ICU admission, and death due to COVID-19. All of these were significantly increased in patients with ILD. Here you can see that 50 out of 7,252 patients living with IPF died, reflecting a 54% higher risk compared to patients without respiratory disease. For patients with other ILDs, the risk was more than twofold higher. The risk of death among patients with ILD hospitalized for COVID is highest for men over the age of 60. Here you can see that men between the ages of 60 and 75 had a 55% mortality rate, and men over the age of 75 had a 62% mortality rate. The risk of death is also highest for patients with IPF compared to non-IPF ILD, and for those who are obese and with FVC less than 80%. COVID can have other serious impacts on patients with ILD. It can trigger acute exacerbations of ILD. There's also a lot of ongoing discussion about post-COVID lung fibrosis in patients without prior ILD, and whether this is a progressive fibrotic disease that should be treated with antifibrotics. I will not get into that here, as this was a separate presentation done during the summit. But we are also seeing patients with mild COVID-19 infections who then develop prolonged respiratory symptoms and go on to have CT imaging consistent with IPF or other fibrotic ILDs. There's thought that in some of these patients, COVID seems to trigger an acceleration of underlying previously undiagnosed interstitial lung disease. The pandemic has also strained healthcare systems, leading to delays in diagnostic procedures such as bronchoscopy and pulmonary function testing. It has at times impacted patients' access to medications such as tocilizumab and to pulmonary rehabilitation. It has reduced access to lung transplantation for our patients, and it has interrupted ongoing and new research studies and clinical trials. Finally, the pandemic has led to significant social isolation for many of our patients, which can be especially difficult for patients with chronic and progressive lung disease. So, knowing that our patients with ILD are at increased risk for death from COVID-19, how do we prevent COVID-19 while also ensuring that we continue to deliver optimal and patient-centered care? This layered approach to risk reduction is a useful model. Vaccination is absolutely essential in our patient population, and I'll spend more time talking about this. But COVID-19 vaccines are not 100% effective. And so additional interventions that are needed to prevent COVID in our patient population. This includes masking, especially at times when there's high community transmission and in places when there may be increased risk of infection, such as doctor's offices or other indoor locations. We have seen our transplant patients do this for years, but it will now be more normalized for patients with other high-risk conditions. And as physicians, we should continue to promote and advocate for community mitigation strategies and public health measures to decrease community spread of COVID-19 in order to keep our patients safe. Vaccination is our most important tool to prevent COVID-19 in all patients, but especially among patients with ILD. All patients with ILD should be fully vaccinated for COVID-19. I still get a lot of patients that are hesitant to receive the vaccine because they worry that the vaccine will worsen their underlying lung disease and that their lungs are not strong enough to handle the vaccine. It is critically important to emphasize to our patients that the only contraindication to the vaccine is a history of an allergic reaction to the vaccine components. Patients with ILD who are taking immunosuppressive therapies or otherwise immunocompromised who have received one of the two mRNA vaccines, Pfizer and Moderna, should also receive a third booster dose at least 28 days after the second dose. This is based on data presented at the ACIP meeting back in July, showing that patients taking immunosuppressive therapies, here shown in pink, have decreased antibody response to the mRNA vaccines. The blue line here represents the antibody response of healthy controls, which is 95 to 100%. Patients who are on immunosuppressive therapies had a antibody response that was between 40 and 90%. Immunosuppressive therapies include active treatment with high-dose corticosteroids, which is prednisone of 20 milligrams per day or more, alkylating agents, antimetabolites, and other biologic agents. Now, what about boosters for patients who are not immunocompromised or taking immunosuppressive medications? It gets a little more complicated, and recommendations are currently evolving. There's data showing that vaccine effectiveness against infection with SARS-CoV-2 decreases over time. This is the Pfizer vaccine, here shown in yellow. This is the Moderna vaccine, here shown in orange. This is all kinds of vaccines among nursing home patients, here in the light blue. And here's vaccine effectiveness among healthcare workers, shown in the dark blue. The good news is that all three vaccines, Pfizer, Moderna, and Janssen, maintain their effectiveness against hospitalization over time. The effectiveness is slightly lower for those over the age of 50 who have received one of the mRNA vaccines, here shown in these orange lines, but it is still very good. This graph is showing vaccine effectiveness since the introduction of the Delta variant. This is real-world data. You can see that the effectiveness of the Pfizer vaccine against infection, here shown in blue, ranges from 50 to 85% or so. The effectiveness against hospitalization, shown in pink, ranges from 70 to 100%. So this is lower than the originally reported effectiveness of the vaccine, and maybe in part due to somewhat lower efficacy against the Delta variant or due to waning immunity over time. The data here for Moderna and here's for Janssen, it looks a little bit better. So based on this data, as of today, which is September 29th, Pfizer has filed for an authorization for booster dosing for the general public. Moderna and Johnson & Johnson may file soon, as this is a quickly changing situation, but the current recommendations only apply to the Pfizer vaccine. So the CDC recommend that people over the age of 65, as well as adults between the ages of 50 and 64 with underlying medical conditions get a booster shot of the Pfizer vaccine. Residents of long-term care settings over the age of 18 should also get a booster shot. People between the ages of 18 and 49 with underlying medical conditions may get a booster shot of Pfizer vaccine based on their individual benefits and risks. People between the ages of 18 and 64 who are at increased risk of COVID-19 exposure and transmission because of their occupation or their institutional setting may also get a booster shot of Pfizer based on their individual benefits and risks. Boosters should be given 6 months after the completion of the initial Pfizer series. So to summarize where we stand as of today, which again is September 29th, all patients with ILD should be fully vaccinated for COVID-19. The only contraindication is an immediate or severe allergic reaction to the vaccine components. Immunocompromised patients or those receiving immunosuppressive therapy should receive a third dose of the mRNA COVID-19 vaccine, which is either Pfizer or Moderna, at least 28 days after the second dose. Patients with ILD over the age of 18 who had received the Pfizer vaccine should consider getting a third dose 6 months after completion of their initial Pfizer series. The next question that comes up is how should immunosuppression be modified in the setting of vaccination? The American College of Rheumatology has excellent and updated recommendation for this that can be accessed here at this website. They state that patients on prednisone, regardless of the dose, azathioprine, oral cyclophosphamide, TNF, and IL-6 inhibitors do not need to modify their medication. Patients on MMF or oral calcineurin inhibitors, such as tacrolimus, should hold their medication for 1 week following each shot. Methotrexate should also be held for 1 week after each of the mRNA vaccine doses, or 2 weeks after the single dose of the Janssen vaccine. Rituxan gets tricky. The recommendation is to schedule the vaccine 4 weeks prior to the next scheduled Rituxan cycle and delay Rituxan 2 to 4 weeks after the final dose. All of these recommendations assume that disease activity allows for these interruptions. For booster dosing, immunosuppression should be held for 1 to 2 weeks after the booster shot. There was no consensus regarding glucocorticoids and interruption of glucocorticoids. They probably don't need to be held, but you should weigh the risks and benefits in each individual patient. I wanted to briefly mention monoclonal antibody therapy. There's a separate talk about treatment of COVID-19 that should cover antibodies. However, this Regen-COVID treatment, which is the 2 antibody combination of casirivimab and imdevimab, has an FDA EUA approval for post-exposure prophylaxis for certain patients. That includes individuals at high risk for progression to severe COVID-19 who are not fully vaccinated or are immunocompromised, which includes taking immunosuppressive medications. So this may be an option for some of our patients with ILD if they had a known COVID exposure and if they meet these requirements. So in summary, patients with interstitial lung disease are at increased risk for severe COVID-19 and have high mortality rates. The risk is particularly high for patients with fibrotic interstitial lung disease who have poor lung function. Appropriate vaccination against COVID-19 in this patient population is critical. Monoclonal antibody therapy may be appropriate for immunocompromised patients with ILD as post-exposure prophylaxis if they're unvaccinated or are not able to mount an appropriate response to vaccination. And booster dosing and modification of immunosuppression may be appropriate for patients with ILD. This is, again, a very ever-evolving situation, and the best recommendations are found on the ACR website. So with that, I will end. Thank you very much, and I will take questions.
Good morning. My name is Nir Goldstein. I'm a pulmonologist and director of the Center for Post-COVID Care at National Jewish in Denver. I expect the next 15 minutes we have to review the pandemic that has devastated the planet for the last 20 months. Will certainly test my lung function. As you know, the COVID-19 pandemic continues to rage in the United States and throughout the planet. Despite effective vaccinations for SARS-CoV-2, viral variants, limited worldwide availability, and vaccinations, and vaccine hesitancy remain significant barriers to containment. While the virus acutely hits older patients the hardest in terms of severity of acute illness and mortality, the long-term effects and chronic morbidity don't necessarily age discriminate, with many young and previously fit people also suffering lingering effects. While there is no universally accepted time period that defines the beginning of the post-acute phase, a growing body of data suggests that some patients with COVID-19, including individuals with mild initial symptoms, will have a variably prolonged course of recovery with persistent symptoms long after they've been clinically tested negative for the disease. And as we struggle through this pandemic, a significant challenge is how to manage COVID-19 sequelae, which may vary from brain fog and fatigue to cardiomyopathy and pulmonary fibrosis. Recently, the term post-COVID conditions was coined by the CDC and is used as an umbrella term for the wide range of physical and mental health consequences experienced by some patients that are present some weeks or months after SARS-CoV-2 infection. We have found it useful in our clinic to phenotype patients into broad categories within the umbrella of post-COVID conditions. Firstly, we have a group of patients with persistent but variable and fluctuating multi-system complaints following sometimes mild acute illness. This is a group that have colloquially been termed long haulers and have received much social and mainstream media attention recently. Secondly, there's a group of patients who meet the definition for post-intensive care and post-hospitalization syndromes that have been characterized with other acute illnesses. And thirdly, there are patients with sequelae of organ damage, for example, cardiomyopathy, pulmonary fibrosis, thromboembolic disease, renal failure, etc. And we'll discuss each of these in turn. This group of patients have had much media exposure and have been variably termed as long haulers, post-COVID syndrome, suffering from chronic COVID, and having long COVID. These are often younger and previously healthy individuals who have found that recovering from from acute SARS-CoV-2 illness isn't the end, but just the beginning of their medical journeys. Many of these patients aren't getting better, often fearing that they will be experiencing the effects for months, years, and potentially a lifetime. Several patient-led initiatives and surveys have been reported. Out of over 200 potential symptoms, top symptoms have included fatigue, brain fog, body aches, headaches, dry cough, dyspnea, chest tightness, and fevers. In this analysis done using smartphone applications, over 4,000 individuals who tracked their symptoms prospectively, about 16% had persistent symptoms lasting more than a month, about 5 to 6% had symptoms lasting more than 8 weeks, and 2 to 3% more than 12 weeks. For those of you who follow the long COVID data, you may notice that the percentage is lower than that cited in many published observational studies whose denominator populations were those admitted to hospitals or attending specialty clinics. Interestingly, individuals reporting more than 5 symptoms in the first week were significantly more likely to go on to experience persistent symptoms, especially if the initial symptoms included fatigue, headache, dyspnea, and myalgia. A syndrome following often viral URI infection from which the sufferer fails to make full recovery has been described previously and variably referred to as post-viral syndrome, myalgic encephalomyelitis, chronic fatigue syndrome, Iceland disease, and roll-free disease. Persistent symptoms were described in 40 to 60% following the SARS global epidemic in 2003, after the 2009 H1N1 influenza A pandemic, and it's also been sporadically described after infections with EBV, Ebola, and West Nile virus, among others. Understanding of long COVID at this time is limited. The multitude of symptoms have so far defied a uniform pathophysiologic process, and given lack of diagnostic criteria or laboratory testing, so-called long-haul COVID should be considered a diagnosis of exclusion. All other well-described complications associated with COVID-19 and other alternative diagnoses must be first ruled out with pertinent history exam and diagnostic testing. This is a list of some conditions that should be considered, but a potential list is much longer in the differential diagnosis of so-called long COVID. So-called long COVID can be considered a multi-system disorder manifesting commonly with respiratory, cardiovascular, and neuropsychiatric symptoms, either alone or in combination. As such, the therapy should be individualized and should incorporate a multidisciplinary approach directed towards addressing both the clinical and psychosocial aspects of this disorder. Given the increased clinical awareness of this syndrome, post-COVID care clinics have opened throughout the US. These clinics should offer a holistic, multi-specialty and multidisciplinary team approach that includes physicians across specialties, psychologists, speech therapists, behavioral health experts, physical and occupational therapists, and social workers. Primary care providers should recognize the syndrome, evaluate for other potential diagnoses, and refer patients to post-COVID care clinics if available. The second group of patients that we'll discuss exhibit findings of post-intensive care unit syndrome, which is defined as new or worsening impairment in physical, cognitive, or mental health status after critical illness and persisting beyond discharge from the acute care setting. This, of course, is a large topic on its own, which we'll bypass for now. I'll devote the remainder of our time to discuss the last category of patients who experience symptoms due to defined abnormalities in organ function as a result of the acute illness. Some examples could include hypoxic brain injury, myocarditis, venous thromboembolism, ATN. We will have a focus on the lung. So various mechanisms of lung injury in COVID-19 have been described, with both viral and immune-mediated mechanisms being implicated, with both epithelial and endothelial injury described. A two-hit hypothesis proposes that an initiating viral insult causes alterations in the lung microenvironment, increasing susceptibility to fibrotic development following a secondary insult, such as ventilator-induced lung injury or genetic susceptibility. While survivors of COVID-19 often present with residual interstitial lung abnormalities, it remains unclear and poorly understood when irreversible post-COVID-19 pulmonary fibrosis is established, because most COVID-19 survivors seem to have ongoing functional and tomographic improvements on follow-up. For example, these chest CT scans of a patient with COVID-19 with severe pulmonary involvement demonstrate progressive improvement during the follow-up period. Initial scans demonstrate diffuse ground glass opacities and consolidations, predominantly in the lower lung lobes. At 3 months after discharge, there's a smaller extension of multifocal bilateral GGOs and reticular opacities, while at 9 months after discharge on the final panel, there are only scarce discrete GGOs. Here again are representative sequential CT scans of a COVID survivor demonstrating progressive improvement as seen on pulmonary 3-dimensional modeling during acute COVID-19 and at 60 and 100 days of follow-up. Areas with increased opacities are marked in red, whereas normal lung areas are indicated in green. This prospective observational study of the pulmonary damage in subjects recovering from severe COVID-19 at 60 and 100 days demonstrated that 1/3 of patients complained of dyspnea at 100 days. CT scans revealed persistent lung abnormalities in 63% of patients, mainly consisting of bilateral ground glass opacities and reticulation in the lower lung lobes, without radiologic signs of pulmonary fibrosis. Thankfully, sequential follow-up evaluations at 60 and 100 days demonstrated a vast improvement in symptoms and CT abnormalities over time. However, patients still displayed impaired lung function, with reduced diffusion capacity being the most prominent findings and occurred in about 1/5 of patients. Our understanding so far suggests that the majority of the patients who contract COVID-19 are asymptomatic or have mild to moderate disease. Approximately 5 to 8% will develop hypoxia, bilateral lung abnormalities, and decreased lung compliance requiring ventilatory support. While most COVID-19 survivors will manifest early pulmonary abnormalities, the duration of which seems to relate to the severity of their acute disease, most patients can expect near complete resolution within 6 to 12 months. However, persistent lung function abnormalities, including restrictive lung disease, decreased diffusion capacity, and fibrosis, can be seen in some patients, often in those who had a more severe course, particularly in those who required prolonged mechanical ventilation. Whether a progressive third form can develop remains unclear, but seems singularly uncommon. Despite overlapping pathways, it appears that the timing, etiology, prognosis, and mechanistic underpinnings of post-viral scarring are different to those of chronic fibrosing interstitial lung diseases. For example, IPF is often progressive and often fatal in patients. Similarly, pulmonary fibrosis secondary to autoimmune causes such as rheumatoid arthritis and scleroderma may similarly progress and often carry a poor prognosis. In contrast, while post-inflammatory changes can be seen in ARDS survivors, progressive fibrosis has not been an important characteristic. Although several therapies are available under emergency use authorization, these are aimed at early stages of the disease and are currently confined to monoclonal antibody therapies aimed at high-risk patients with mild to moderate disease and include several combination of monoclonal antibodies. Other antiviral agents are in development. Other acute therapies are aimed at sick or hospitalized patients, including the antiviral remdesivir, anti-inflammatory drugs, mostly dexamethasone, and immunomodulatory agents like baricitinib and tocilizumab. The utility of these treatments are often variable and based on the timing and severity of illness. Currently, there's no proven options available for the treatment of post-inflammatory COVID-19 pulmonary disease or fibrosis. In terms of preventing potential progressive or fibrotic disease, Theoretical complementary strategies to reduce the likelihood may include early identification of risk factors, both clinical and biomarkers, earlier, more intense and prolonged inhibition of viral replication, long-standing inhibition of the inflammatory response, and potentially earlier administration of antifibrotic drugs. However, the efficacy of using antiviral, anti-inflammatory, antifibrotic therapy in the post-acute setting will still have to be demonstrated in clinical trials and personalized. Antifibrotic drugs such as pirfenidone and nintedanib have anti-inflammatory effects as well, and perhaps can be used even in the acute phase of COVID-19 pneumonia. But present evidence for these antifibrotic drugs in COVID-induced fibrosis is absent, and there's certainly an unmet need for high-quality research to formulate future recommendations. Currently, there is one recruiting study in the United States for nintedanib that's expected to be completed in 2024. There are no studies recruiting for pirfenidone in the United States. There are recruiting studies in the US for the mTOR inhibitor sirolimus and a compound called Bio300, which is a genistein-based compound initially developed as a radiation countermeasure. Pulmonary rehabilitation in the acute stage, and particularly in the recovery stage, seems to be beneficial with little downside. It improves respiratory function, exercise endurance, self-care in daily living activities, and psychological support. However, scientific research is still required to define benefits in the post-COVID setting. Lastly, we'll review the evidence for steroids in the post-acute phase. In this prospective observational study of 837 patients who survived hospitalization for SARS-CoV-2 infection, 7% of patients had persistent interstitial changes on CT at 6 weeks after hospital discharge. The majority of these patients had an organizing pneumonia radiographic pattern consisting mostly of subpleural ground glass infiltrates in a mid to lower lung zone distribution. Patients were offered treatment with corticosteroids at 30 milligrams a day with a taper over 3 weeks if they had organizing pneumonia changes that affected more than 15% of the lung with associated restrictive abnormality and persistent symptoms. Of the 30 patients who received corticosteroid treatment, all reported improvement in breathlessness and physical functioning and had objective improvements in lung function. The mean relative increase in DLCO was 31% with a 10% increase in FEC. A representative CT shown of a previously fit 57-year-old male demonstrating a radiological pattern of organizing pneumonia with predominant peribronchial and perilobular dense consolidation and mild traction bronchiectasis in frames A and B, while follow-up imaging after 3 weeks of oral steroids showed resolution of consolidation with mild residual ground glass opacities and fine subpleural reticulations in frames C and D. Unfortunately, there's no way to know whether these patients would have recovered on their own without therapy, and as patients in the study were given a clinical diagnosis of OP, the underlying histopathology is not known. Despite emerging data at present, the long-term pulmonary consequences of COVID-19 remain mostly speculative, and the concern remains that given the huge number of patients affected by this pandemic, even rare complications may have major health effects at the population level going forward. I thank you for the opportunity to share this information with you, and I look forward to your questions and comments. Thank you.
Hello and welcome to our Q&A session, and thanks for a couple of great talks. Just a brief reintroduction. First, we're here with Anna Podolonchuk from Weill Cornell, as well as Nir Goldstein from National Jewish Health. Thank you guys both for bringing us your knowledge and experience around COVID-19 and interstitial lung disease. I welcome everybody out there listening to submit questions through the chat. We're excited to get into a really great conversation here. So maybe we can start with this for you, Dr. Podolonchuk. Your recording was on September 29th, I think it said. And of course, a lot has changed since then in the world of booster shots and updates from the CDC and FDA and other organizations around the world, for that matter. This is a worldwide audience that we have here. So would you care to maybe update a little bit some of the things that have happened just in the last 6 weeks?
Absolutely. So I gave this talk at the end of September, and I knew that we were dealing with an evolving situation and that the recommendations were likely to change in between the time that I gave my talk and now. So when I gave my talk, the booster dosing for the Pfizer vaccine was just approved. And then in the interim since then, we've also had approval for booster dosing for the Moderna vaccine as well. So currently, patients and people, really anybody who's received one of the mRNA vaccines should get a booster, especially if they have an underlying condition, if it's been at least 6 months since their prior vaccine. Now, for patients who are immunocompromised, they should also get as I mentioned in my talk, a third dose of one of the mRNA vaccine, which is different from the booster dose. And now we're starting to talk about a fourth dose, which is a booster dose for the immunocompromised patients. So again, there's going to be more recommendations about the fourth dose coming, but there's likely going to be a need for a fourth dose, a booster fourth dose for immunocompromised patients if it's going to be 6 months from their prior dosing.
Yeah, I'm noticing myself, a lot of people, and even in healthcare, even the people that work in the pharmacies that administer these vaccines, my patients will tell stories of going to the store for their vaccine, for their third dose. Say someone who's had Moderna for their first 2 doses, they're immunosuppressed on mycophenolate, or even transplant patients, and then they get there and they say, "I'm here for my third dose," and the person there is trying to administer the booster dose, and hopefully they're a smart enough patient to have not only known what the right dose, what the right plan was, and to recognize that the wrong plan was being created in the store there. And sometimes even after the explanation, the pharmacist or manager or whoever at the store might have even a continued misunderstanding, and the patients sometimes leave only to come back or go to another store. Have you experienced that same thing?
Absolutely. It's very confusing. And I think even as doctors, we can't really keep track of what's a booster. I mean, Pfizer is easy because it's the same dose for all the shots. Moderna's confusing because the dosing for the booster is a half dose. It's a lower dose. And so people have to understand what is the difference between the original 2 shots and for immunocompromised 3 shots of the full dose Moderna versus the booster for Moderna, which is a half dose.
Yeah, good to hammer that one home, I think.
One more question for Dr. Podolonchak. How you compare, is there data to compare how the effect of vaccination is dissipating over the time between the 3 common vaccines that it's at least available here in the US?
Yeah, so the data I've seen, and I've presented a little bit in my talk, but again, it's ever evolving, is that Pfizer definitely wanes over time. And, it seems to have pretty good efficacy for 6 months, but the protection after 6 months wanes. Moderna seems to hold up a little bit better, but I do think that there's also evidence that Moderna wanes after 6 months. And Janssen & Janssen, there's the least data on the Janssen vaccine from Johnson & Johnson. There's currently no recommendation for a booster, although a lot of us do think that for anybody who's, especially if they're immunocompromised, if they've had a first dose of the Johnson & Johnson vaccine, they should potentially, after the second dose, they should consider getting an MR vaccine. So for Johnson & Johnson, it's 2 doses. It was originally 1 dose, but there's probably better protection if you get a booster from one of the mRNA vaccines. But they do all, they seem to wane. We don't yet have any recommendations for a third dose of Johnson & Johnson. There seems to be pretty good protection against severe hospitalizations and death, but the protection against infection definitely wanes.
Dr. Goldstein, are there any tools that one can use to assess the post-COVID syndrome, the post-COVID symptom burden? Are there tools either to assess the existence of whether someone has post-COVID and or its severity? I know it's a multi-system disease, but maybe there's scoring systems or something along those lines.
Yeah, they are. But one of the major challenges we face is that we really don't even have a standardized definition of what post-COVID conditions or syndrome means. And as I try to explain in the talk, it's really multiple diseases sort of that fall under that umbrella term. The pathophysiology, of course, of somebody who has dyspnea because they have post-ARDS pulmonary fibrosis must be different to the cause of unexplained dyspnea, with normal CT or imaging. And so there are symptom scores, but there are no ways yet to, or definitions or case definitions or tests that confirm a post-COVID condition. We are still in the phase really of just chronicling this, figuring out all these different diseases within this term. And so it makes all scoring systems or scores really not that reliable because you're measuring different things.
So with that said, there's the post-COVID clinics that you described, and there are many of us have them at our hospitals. There are more coming in as time goes on. Although there are certainly too few such clinics and specialists in this to satisfy what would be the needs for the population. So who should be sent to a post-COVID clinic, assuming they're available locally? Is it all patients who've had COVID, all patients who've been hospitalized with COVID, all patients who might have been perceived to have some symptoms, or is it only severe symptoms? It's sort of hard for me to decide this sometimes.
Yeah, that's a great question, and it would be terrific if everybody could be seen in these multi-specialty and multidisciplinary clinics that really offer a sort of overall approach. But I think the burden of the disease is too great, and this is something that will have to be managed to a large extent by primary care providers and community providers. I think it's clear that patients who have severe sequelae of acute disease would benefit. So, if you have persistent radiographic or spirometric abnormalities, but in many patients who have symptoms in the absence of sort of defined disease, we will probably over time have to figure out rehabilitation and psychosocial care systems that bypass really multi-specialty clinics.
One more question for everybody, actually. Are the antibodies markers of protection, and do the levels matter? So what is the cutoff? And the person who was the question got this question all the time, and we all do, I think.
Yeah, I'll start. So in my practice and in our center, we don't routinely check antibody levels after vaccination. There's no formal recommendation to do that. And so I don't know what the cutoff would be. I do see anecdotally that some physicians, and I work with a lot of rheumatologists, and they actually more frequently tend to check antibody levels. And if there is no, if the antibody levels are negative, then they tend to just keep vaccinating and keep giving doses to immunocompromised patients. But that is not entirely based on guidelines. It's just kind of the way they practice.
Yeah, I think our approach is similar. There is no gold standard antibody test, and so there are a variety of tests out there which have received variable degrees of EUA, and some have been some levels of some tests have been correlated with neutralizing antibody levels, and others haven't, and so you never really know what antibody level is protective from the disease, and so usually it does not help you too much to check those because it does not often change your treatment, except for sometimes patients with severe immunosuppressions, or patients on rituximab, for example. We are more comforted if they develop antibodies at the time, and perhaps we will be more because apart from revaccination, we have these monoclonal antibodies, and now they're EUA approved for post-exposure prophylaxis, but there are tests undergoing for even pre-exposure prophylaxis in some high-risk individuals. And so it may sort of guide you towards earlier therapy or prophylactic monoclonal antibody use, and hopefully soon oral antivirals.
Yeah,
I always find myself describing to the patients that these tests aren't an assessment whatsoever of a T cell response, and that's not something easily measured. And there are patients with antibodies without a T cell response, and then vice versa. There are patients who don't have antibodies, but they would have a T cell response if it were measurable. So I would share the experience of the speakers that I think I can count on one hand the number of times I've ordered the test. And
yeah, in our center we'll actively discourage the patient or pursuing that type of testing.
I was intrigued by one of your, Dr. Goldstein, one of your slides with sort of the directions after COVID, or maybe it was, you both might have had a slide like this. And so the question's for both of you, that some patients have an upward trajectory in their lung function. Some have a downward trajectory afterwards, after the infection. And of course, that's probably unpredictable, but I think there are pretty few that have the progressive phenotype after COVID, and more likely to have the regressive phenotype, if you will. I wonder to myself if those might not just be patients who had an undiagnosed interstitial lung disease prior to their infection, and then it was uncovered through the testing and experience of being infected. What do you guys think?
I am sorry, but I think I lost some internet connection and missed the major point of your question.
I can start answering that. I mean, the question was on how commonly do we see progressive pulmonary fibrosis, and it really, those patients who have progressive disease after a COVID infection just had an underlying undiagnosed or preclinical ILD. I think I tend to agree with you that that's kind of my impression, and whether they've had undiagnosed ILD, or maybe they've had some interstitial lung abnormalities that they were previously noted, or even potentially that they were at risk for pulmonary fibrosis and were going to develop it from some other insult in the future, and COVID was something that just triggered it. I tend to think that that's the majority of the patients where we see the progressive disease and the decline in FVC. The data we have, the limited data that's presented, is that, like you said, the majority of patients kind of remain stable or do in fact improve, albeit slowly over time.
Yeah, I'll echo that. I think that's right.
Yeah, I'm sorry. It seems that we are running out of the time. There's still many great questions left here from the audience, so we apologize that we couldn't answer everything. But thank you everybody for participation, and please continue to listen to the sessions today.
Thank you.
Hello, my name is Dr. Lauren Troy. I'm a respiratory specialist at Royal Prince Alfred Hospital in Sydney, and it's my great pleasure to speak on the topic of cryobiopsy in the diagnosis of interstitial lung disease, with reference to a recent study that I was fortunate enough to lead called Coldice, and some other relevant studies. These are my disclosures. So I'm very fortunate to live in sunny Sydney, and we are heading into spring when these beautiful jacaranda trees start to bloom. Under normal circumstances, it's a really lovely place to live, but like many parts of the world, a big thing called the pandemic is limiting some of the joy, but we hope to get back to some of this freedom very soon. And it's a particularly great place in normal times for interstitial lung disease research and clinical activity. And we have one of the largest clinics in the country. And we've been very fortunate to collaborate with many people across the world, including many of you in the States, for research and clinical practice. And I hope to share some of the insights from our Australian experience. Well into the conference, the concept of ILD diagnosis is a very familiar one. It, as is well understood, is derived from multidisciplinary discussion, which really is about an amalgamation of clinical, serological and radiologic data. And in most cases, this generates a reasonable clinical diagnosis that can formulate subsequent management decisions and prognostications. But unfortunately, up to 30% of patients who go through this process still may come out the other side with an indeterminate or low confidence diagnosis. And the unclassifiable interstitial lung disease patients often will find themselves without a specific treatment protocol and uncertain prognosis. And this is because of some of the limitations of sensitivity of our investigations. And so this sometimes leads to a biopsy to help clarify the underlying diagnosis. The biopsy has evolved over time, and back in the 1970s, the only way that biopsies of the lungs could be achieved was through an open thoracotomy with significant morbidity and mortality. Transbronchial biopsies were developed and adopted widely in subsequent years, but they were very limited because of the small sample size and the crush artifact and the fact that tissue is really only taken from the airways. A video-assisted thoracoscopic approach was widely adopted in the 1990s, yielding a similar amount of tissue to the open thoracotomy and lower morbidity and mortality. And so this has been really what would be considered the gold standard for tissue sampling for the following years. But in the last 10 years, there has been the development of the cryobiopsy, and that's the basis of this talk, and really ongoing research into how we can get better tissue samples with less impact on the patient. You can see here from the PubMed search that there's been a very exponential interest and publication output in cryobiopsy since that time. And perhaps the tapering off in the last 12 months relates to the limitations around the pandemic. So surgical biopsy yields a very high histopathologic diagnosis, but at the cost of severely impacting the physiology of an already stressed system. So there is a significant right to left shunt of perfusion through the non-ventilated lung, which leads to mechanical stress, persistent and some persistent hyperperfusion can develop, particularly as hypoxic pulmonary vasoconstriction tries to redivert blood to the ventilated lung. The increased gas content and VQ mismatch will elicit pro-inflammatory responses and can set up an acute lung injury, which is a well-defined risk factor with an acute exacerbation of ILD occurring in a substantial proportion of patients who proceed to surgical lung biopsy. And you can see these other complications are also well described. So the cryobiopsy has a lower diagnostic yield. Across a number of meta-analyses, it's seen to yield about an 80% histopathologic diagnosis. And is that good enough has been the question that has been asked over many editorials and in forums such as this. The tissue size is markedly smaller, as you can see from these pictures. The sample is taken from the bronchoscope, so transbronchially. It is done not under direct vision, but with the use of fluoroscopy. And so in some ways, it is non-targeted. but it's done with reference to the HRCT to locate the most ideal situation to sample, and then the probe is moved out to the periphery of the lung, and the freezing occurs with the aim of sampling diagnostic material. So we developed the Coldice study in order to answer the question of how accurate the cryobiopsy was. We designed the study to sample transbronchial cryobiopsies and the much larger surgical lung biopsies from each individual enrolled to the study. And we sought to establish whether or not there was agreement between these two samples for both a histopathologic diagnosis as well as at the final diagnosis at the multidisciplinary discussion. So every enrolled subject proceeded to two forms of biopsy within one operation. Subjects had cryobiopsies taken and then subsequently surgical lung biopsy. We took 4 to 6 cryobiopsy samples and 2 samples from a surgical perspective from the ipsilateral corresponding lung. Those 2 surgical samples were taken from separate regions of the lung, and we matched those locations with the cryobiopsies. As mentioned, we looked at the agreement between the cryobiopsy and the surgical lung biopsy at the histopathologic assessment. And then we looked at the outputs at the multidisciplinary discussion. And each of those exercises was blinded for all of the investigators and particularly the histopathologists. And so we looked at the histopathology in 2 different ways. Firstly, we followed the ATS-ERS guidelines for the usual interstitial pneumonia classification scheme. And this more simple way of classifying tissue samples allowed for us to power the study, and it was quite an easy rubric for us to apply when we're looking at diagnostic agreement for our primary endpoint. So we grouped usual interstitial pneumonia and probable usual interstitial pneumonia together, again because in most cases this will mean the same diagnosis. And you can see that we had a substantial agreement between the cryobiopsy and the surgical lung biopsy for this classification. In fact, the concordance for the 33 patients who had definite or probable UIP in their surgical sample was 84.8%. And when we looked at the more specific diagnostic patterns, so UIP felt to be related to idiopathic disease versus hypersensitivity pneumonitis versus other diagnoses, again, the agreement for idiopathic UIP in the cryobiopsy and the surgical lung biopsy was very high at 81.5% with a kappa value of 0.61. So our primary paper, as I've said, looked at the agreement across all of the histopathologic categories using the ATS-ERS guidelines and then those other more granular diagnostic classifications. And when we looked at the ATS-ERS guideline categories, the agreement between the 2 samples was 70.8% with a weighted kappa of 0.7, which is high. And we looked at the agreement for those specific granular patterns that I mentioned. The agreement was very similar at nearly 70% with a kappa of 0.47. At the MDD consensus, the agreement again was high at nearly 77% with a kappa of 0.62. And when we analysed the utility of the biopsy, so how often did it change the diagnostic confidence or provide an unanticipated diagnosis, both samples performed very similarly. We looked at the group that had definite or high confidence with their cryobiopsy at MDD diagnosis, and there were 39 of these. And really reassuringly, the majority, in fact, 95% of those were concordant with the surgical lung biopsy at the multidisciplinary diagnosis, showing that a high confidence cryobiopsy is extremely reliable. The reliability dropped as the confidence levels dropped according to the MDD diagnosis. So there were more samples that did not agree with the surgical samples, the lower the confidence at MDD, which would be anticipated. But when we looked at those patients that did have disagreement at the MDD, only 6 patients would have been reclassified as a high confidence diagnosis by the surgical biopsy. So the surgical biopsy really would have only aided 1 in 10 patients across the sample. Really showing that the cryobiopsy is an excellent first-line investigation for patients who have an unclassifiable interstitial lung disease. This is an example of a patient, a 69-year-old man, never smoker, who had recent domestic bird exposure and negative autoantibodies with the following HRCT scan. The pattern was considered not typical for the usual interstitial pneumonia pattern, and nor did it have the hallmark features of other conditions such as hypersensitivity pneumonitis or any other underlying pathognomonic features. So the patient enrolled in the study had a cryobiopsy in the middle panel, which demonstrated fibroblast foci, as did the surgical sample. There was fibrosis. There was interspersed with normal areas of lung, and both samples unequivocally showed the usual interstitial pneumonia pattern. And so this patient at MDD had a high confidence diagnosis of idiopathic pulmonary fibrosis for both samples, even though the imaging was not definitive. So the primary paper conclusions were that the Coldice study showed a high agreement between transbronchial lung cryobiopsy and surgical biopsy for ILD diagnosis. And we postulated, and this has been also borne out in other literature, that the transbronchial lung cryobiopsy is a valid alternative to surgical biopsy. Diagnostic confidence is clearly lower when it comes to cryobiopsy when we ask our pathologists to analyse these samples. And the reasons for this are the size difference clearly is going to impact the amount of tissue available for review. The anatomy is also really key because a surgical sample comes from the thoracoscopic or pleural surface and samples entire segments of lung, whereas a transbronchial segment will only sample the material adjacent to the airways. The advantage of the cryobiopsy over the forceps biopsy is that you get a far larger sample than you would from a forceps, and crush artifact is not a problem with the cryobiopsy. But there are some key anatomical structures that may be missed in that procedure, even if the sample is bigger than the forceps. And then the other reason for low diagnostic confidence is that the guidelines set out a number of key features that need to be met in order to call a tissue sample UIP. And in particular, there is a request to have a predominantly subpleural paraseptal distribution of the honeycomb change and the fibrosis for it to be a confident usual interstitial pneumonia. And if you are missing the subpleural regions or the paraseptal regions because of where you've sampled, then you may not have enough anatomic features to make a confident diagnosis. So it's important before embarking on a really enthusiastic, everybody gets a cryobiopsy approach, that we understand its limitations. We, in the study, wanted to look at some secondary points to see if we could identify features in the cryobiopsy that were predictive of UIP in the corresponding surgical lung biopsy, with the aim of providing guidance for pathologists when they're interpreting these samples that may enhance their confidence. And we also wanted to look at which procedural features were associated with agreement between the two biopsies, perhaps providing further clues to proceduralists on how to sample best to get the highest yield output. And we published these findings this year. So just to quickly summarize, in the surgical samples, we always saw subpleural and paraseptal fibrosis. That was very easy to identify in the surgical samples of the 33 patients with UIP-IPF. However, this was very seldom present in the corresponding transbronchial lung cryobiopsies. All 4 features were observed, all 4 of those UIP ATS-ERS classification features were present in the surgical biopsy in 94% of the time, but only 21.2% of the time in the corresponding transbronchial sample. And you're much more likely to find 3 out of 4 features in a cryobiopsy sample. But what we found was that 3 out of 4 still yielded a very high likelihood of UIP. In fact, it yielded an odds ratio of 23.4 with respect to finding patchy fibrosis, fibroblast foci, and absence of alternative diagnostic features. So really strongly predictive of UIP. And so this would suggest that if you do not have subpleural or paraseptal fibrosis clearly identifiable on your cryobiopsy, that you can still be reasonably confident that the sample is showing UIP if those other 3 features are identifiable. And the sensitivity and specificity are high. And the final thing was that we found that the number of samples was the only predictive diagnostic feature, procedural feature that predicted a greater chance of getting an accurate answer with respect to the corresponding surgical biopsy. We actually found that the inflection point in our curve was actually 5 samples. So, but we were not powered to really to address this question. So this is really just a hypothesis generating question, but it certainly would suggest that the more samples you take, the more likely you are to get an accurate diagnosis. And it has to be balanced against risk to the patient, because each sample does actually come with a risk of bleeding and pneumothorax. And so we do have to be cognizant of those risks. But we do see that the literature also supports taking more samples. So this very large cohort of nearly 700 patients published by Claudia Ravaglia and colleagues, Venerino Paletti as the senior author, did show that the diagnostic yield certainly improved with the number of samples, and they found that even taking 2 or more samples was much more likely to yield a diagnosis than 1 sample alone. And certainly there's also evidence to say that more than 1 lobe should be sampled when doing cryobiopsy. So our secondary analysis showed that the guideline criteria of subpleural paraseptal fibrosis was not really essential in the cryobiopsy. You could still make a confident diagnosis of UIP without those features, as long as other criteria were met. And in the wake of a lot of uptake of the cryobiopsy across many centres, the American College of Chest Physicians has published a very detailed guideline on how to safely perform cryobiopsy, and there no doubt will be further updates as more evidence is available. So finally, the key ingredients of how to incorporate cryobiopsy into your clinical practice. Well, I would say it's a very useful diagnostic modality as long as the patient is well chosen, and of course in the appropriate setting, which involves experienced proceduralist, well-equipped hospital, a pathologist who's comfortable with looking at these small samples, and ideally access to an experienced multidisciplinary discussion. And it's really helpful for the pathologist to consider reporting diagnostic confidence levels, which will help inform the subsequent multidisciplinary diagnosis, as shown by the evidence from Coldice. And I'd just like to thank the organisers of the PFF Summit for the opportunity to speak. Thank you.
Hi, I'm Jonathan Chung, chest radiologist at University of Chicago Medicine, and I have the great pleasure of talking about HRCT, indications, and diagnosis. These are my disclosures, none of which are directly pertinent to this talk. All right, so what should you get from this talk? Hopefully after this talk, you'll be able to list the common indications for high resolution chest CT. And then after that, you'll be able to describe the basic diagnostic approach to pulmonary fibrosis relative to the UIP pattern. All right, so let's talk about indication just briefly. So these are not set in stone, but I think most people would agree, and certainly the American College of Radiology would agree, that evaluation of suspected or known diffuse lung disease, including interstitial lung disease and pulmonary fibrosis, is a key indication. Other things would be also small airway disease. Remember, we do inspiratory and expiratory phase imaging with HRCT, so really good for air trapping as well. Things like hypersensitivity pneumonitis, asthma, obliterative bronchiolitis. Also can provide guidance in the selection of the most appropriate area for biopsy. If the patient was to be further evaluated with surgical lung biopsy, then certainly you don't want to sample areas that are most fibrotic. You probably want to sample areas that are less fibrotic, and certainly HRCT can help in that regard. And then the visual estimation of the extent of diffuse lung disease, CT is extremely good at that. One thing that I want to add, though, and this isn't something that you would see in the literature right now because it's relatively new, is with the antifibrotics having been FDA approved and now I think increased in clinical usage, establishing a progressive phenotype, so a CT pattern where the fibrosis is slowly increasing or maybe rapidly increasing, is also now important. So I would add that to sort of the indications for HRCT as we move forward. Okay, so let's say you have an HRCT patient with pulmonary fibrosis or diffuse lung disease. How do you approach it? Because it can be very challenging. You have probably upwards of hundreds of images, sometimes up to 1,000 images. How do you evaluate all that? It can be almost overwhelming. So I think that this 3-step process is probably the best way to go. This is how I train my residents, how I train my fellows on how to interpret HRCT. And the first step really is to figure out what the main patterns are. So what do I mean by patterns? I mean the findings. So things like reticulation, honeycombing, traction bronchiectasis, ground glass opacity consolidation. What are the actual things on the HRCT, actual findings within the lungs? And usually it's going to be more than one thing. So very seldom is it just one thing. Usually it's a combination thereof. Once you know those patterns, the major patterns, you kind of put that in your back pocket and try to figure out what the distribution is on that HRCT in 2 planes really. So axial plane, within the axial plane, the CT scan. And so we're talking like peripheral, central, diffuse. And then within the zonal plane, so up and down. Is it upper lung preponderant? Is it mid? Is it lower lung preponderant? Or is it a diffuse process? But you really need those 2 sets of distributions. So once you have those distributions, you put those in your back pocket. And then the last step really is to figure out, are there any other findings or clinical data which might help you in terms of your diagnostic approach? So for example, if you have someone with a dilated esophagus with gas fluid level, you're wondering if the patient has esophageal dysmotility, you're wondering if the patient has an underlying diagnosis of systemic sclerosis, and perhaps their ILD or pulmonary fibrosis is simply related to systemic sclerosis, things like that. So let's talk about the fibrotic patterns in a little more detail. So the first 3 patterns I'm showing here, reticulation, traction bronchiectasis, and bronchiolitis, and honeycombing, are all findings of pulmonary fibrosis that we see on CT. Other important patterns that we see are things like ground glass opacity, mosaic attenuation, and consolidation. So because really the fibrosis is really what we're going to key on in this talk, let's talk about reticulation, traction bronchiectasis, and bronchiolitis first. So here's a patient with a peripheral predominant pulmonary fibrosis pattern, and we see these tiny little lines in lung periphery over here. So these are areas of reticulation. So those of you guys who took Latin, you know that rete, the root rete, means lattice-like or a net-like pattern. And that's what these are. These are little lines superimposed on each other. These are the earliest findings of pulmonary fibrosis that we see on HRCT. If you look very carefully, you see tiny little cysts here in the lung periphery as well. Those are areas of traction bronchiolitis, probably maybe can hallucinate out here in the lingula as well. And so those are sort of the next level up in terms of severity of pulmonary fibrosis. Here's another patient with diffuse lung disease and some pulmonary fibrosis. But here, in addition to reticulation, we also see some ground glass opacity. So ground glass opacity is essentially white stuff in the lungs, smudgy white stuff in the lungs that are not so opaque you can't see through it. So even though there's increased density, increased whiteness within the lungs here, you can still see the underlying pulmonary architecture in there. So we call that ground glass opacity. As opposed to more centrally within the parabronchovascular region, we see denser white stuff, denser opacity. And there you can't see the underlying pulmonary architecture through it. And so we call those areas consolidation. Nice pattern here. In the axial plane, we actually see that there's relative subpleural sparing. So the most peripheral portion of lungs are spared. And this is a beautiful look for an NSIP pattern, non-specific interstitial pneumonitis pattern, which we most commonly see in patients with connective tissue disease. And for those of you guys with hot eyes, you guys probably saw the dilated esophagus here with internal gas fluid level suggesting esophageal dysmotility. So this patient has systemic sclerosis-related interstitial lung disease. Here's another example here. On the left, we have our inspiratory image. On the right, we have our expiratory image. So one of the things that differentiates an HRCT from a regular chest CT is that in addition to doing a inspiratory phase CT, we also do an end expiratory phase CT. So on the right here, we have an end expiratory CT. And the only reason we do that in the setting of HRCT really is to look for air trapping, expiratory air trapping. So how do you identify air trapping? Well, usually on the inspiratory image, you're going to see the areas of mosaic attenuation, these sort of dark areas, these polygons of darkness, sometimes more confluent. And on expiratory imaging, so at end expiration, oftentimes we'll double breathe our patient. We'll have the patient take a deep breath in, blow it out, take another deep breath in, and then blow it out. And at the second end expiration rate, that's when we have them hold their breath. These patients are often dyspneic, so it helps to double breathe these patients so there won't be a lot of motion artifact on the expiratory phase. On the expiratory phase, we see that these areas of low density on inspiration stay as dark, as hypodense on expiration as on inspiration. So we know that these are portions of lungs that aren't letting go of the gas, because when you normally expire, the lungs should turn homogeneously gray because there's going to be more lung tissue, less gas in there. So more density, more electron density means more whiteness within that image. And that's exactly what you expect to see, but except here in these areas of blackness on the expiratory image, these areas stay equally as black on expiration, inspiration. These are areas of air trapping. Okay, so once you figure out what findings are on that HRCT, so reticulation, traction bronchiectasis, and bronchiectasis, honeycombing. I haven't shown you an example of honeycombing, but don't worry, I will show you an example of honeycombing. What do you do? What do you do after you have those findings? We talk about distributions, and again, distributions in two planes. So in the axial plane, within the axial CT scan, and then in the zonal plane. So in the axial plane, you have some options. Is it peripheral predominant? Is it central lung preponderant, or even peripheral with subpleural sparing? We lump those together. If you have someone with a peripheral predominance with subpleural sparing, from a diagnostic standpoint, that acts like central lung preponderance. Or is it diffuse in the axial plane? And the zonal plane, so zonal plane means essentially up and down, is it upper or mid lung preponderant? Is it lower, or is it diffuse in terms of the distribution? So once you have those things, once you sort of figure out what the main pattern are and what the distributions are, how do you approach it? Well, the best way is to use the multi-society clinical practice guidelines relative to the UIP pattern, right? So there's essentially a 4-tier system: UIP, probable UIP, indeterminate for UIP, or alternative diagnosis. Right? And of these patterns, probably the UIP pattern is the most important, because if I say something is UIP and HRCT, well over 95% of the time, it will be UIP and pathology. And that means that we've essentially obviated biopsy. So if you have a UIP pattern in HRCT, in the vast majority of cases, you have obviated biopsy, unless there are other sort of factors which are sort of telling you that it's not UIP, right? It's going to be something else, And when I say UIP, I'm sort of saying UIP that sort of makes you think about idiopathic pulmonary fibrosis. Certainly, UIP is an imaging and histological pattern that can have other causes, but at most clinics, I think UIP would be most often seen in idiopathic pulmonary fibrosis. So how do you diagnose UIP on HRCT? Well, you have to have all these things: peripheral vasopredominant, reticulation with subpleural honeycombing. You don't necessarily have to have traction bronchiectasis or bronchiectasis, but very often you will have it. And then the most important thing is absence of features that suggest alternative diagnosis. So here's a beautiful example of UIP here: peripheral vasopredominant. Beautiful example of honeycombing. We see these fibrotic cysts lining up in rows and frankly stacking upon each other. And then no other findings here that suggest alternative diagnosis. Take it to the bank. This is UIP. No reason to biopsy this patient. Next pattern we're going to talk about is the probable UIP pattern. And so probable UIP is very easy. If you know what UIP is, more or less you know what probable UIP is, because it has exactly the same pattern, taking some liberties here, but exactly the same pattern as UIP, except there's no subpleural honeycombing. One caveat is that we certainly do like to see some peripheral traction bronchiectasis and bronchiectasis, but I will say in patients with any sort of significant pulmonary fibrosis, if you look hard enough, almost always you will see some peripheral traction bronchiectasis. But that's, again, only if you're looking very carefully. The last part of this probable UIP pattern is that you don't want to have any other findings that suggest alternative diagnosis. And again, that's very, very important. No findings that suggest alternative diagnosis. Okay, these probable UIP patients, if we were to biopsy them, 80 to 90% of the time, they're going to have UIP and pathology. That's why they're called probable UIP. And the older you get, so if you get patients who are older than 60, say, then the chance of getting UIP and pathology is even higher, over 90%. Here's a nice example of probable UIP on HRCT. We see peripheral basal predominant pulmonary fibrosis, a little bit of traction bronchiolitis. Next example of probable UIP. And so now if we know that someone has a high pretest probability of IPF and they have a probable UIP pattern, we essentially don't biopsy these patients. Again, unless there are other factors that tell you that this patient is a little bit odd, it doesn't feel like IPF, and perhaps we need to pursue surgical lung biopsy. The next category is indeterminate for UIP. And I think this is an important category. So in the previous version of these guidelines, there was no category for hard cases. And so this is essentially for hard cases, either cases that are very mild or they just don't look like any of the other categories or any other patterns. And so now we have this category for those more difficult cases. And no one really knows what these are as of yet, but certainly now that we have this category, we can study these sort of indeterminate cases in more detail. And the last category here is the alternative diagnosis category. And so these are essentially either patterns or findings or collections of findings that don't feel like UIP, they feel like something else. So the distribution isn't right, or there's too much white stuff in lungs, too much ground glass opacitor consolidation in lungs, which really aren't findings of UIP or diffuse nodular lung disease, diffuse cystic lung disease. You know, a lot of mosaic attenuation or air trapping, right? So air trapping, you typically don't see a significant amount of it in patients with UIP. UIP is especially in the setting of idiopathic pulmonary fibrosis. If you see significant ear trapping, it really draws you away from that diagnosis and more toward diagnoses like hypersensitive pneumonitis, sometimes connective tissue disease, and even sarcoidosis. And then we have other findings, other non-pulmonary findings like pleural plaques or dilated esophagus, which again draw you away from a UIP diagnosis. So here's a patient with mid-upper lung preponderant mass-like fibrosis, obviously with beautiful calcified mediastinal and hyalurolymphadenopathy as well, and some perilymphatic nodularity. This patient is sarcoidosis. That's an alternative diagnostic category. Here's another patient with sarcoidosis. We see diffuse nodular lung disease with a perilymphatic pattern. So these nodules are sort of clustering where the lymphatics like to live, along the peribronchiovascular tree, along the subpleural portion of lung, along interlobular septa, along fissures. Beautiful pattern of sarcoidosis. This alternative diagnosis category certainly does not feel like UIP. Here's a nice example of consolidation. So certainly an alternative diagnostic category here. Consolidation to this degree certainly is not seen in patients with UIP. And so this is actually a nice pattern. We see this perilobular prominence of consolidation at the lung bases. And so this is a very characteristic pattern for organizing pneumonia. And in my experience, very often seen in drug reaction, giving this perilobular prominence of consolidation, something that people don't really talk about. And here's another patient, and I think this would be the second to last example I show you. We see a beautiful example actually of UIP pattern of pulmonary fibrosis, but with pleural plaques. So we know this patient almost assuredly has asbestosis. And here's another patient with basal predominant pulmonary fibrosis, reticulation, a little bit of ground glass opacity, exuberant traction bronchiectasis. But again, for those of you guys with hawk eyes, very dilated esophagus, internal gas fluid level, this patient has systemic sclerosis. So take-home points, I think we talked about sort of the indication for HRCT. I think one of the newer indications for HRCT really should be in defining a progressive phenotype, given the antifibrotics that we now have in our armament for treatment of patients with progressive pulmonary fibrosis. Once you know a patient has pulmonary fibrosis and you have a good HRCT scan, you should approach it using a UIP-centric approach, unless there's a reason to think that patient has some other underlying diagnosis. Thank you very much for your time. I hope you learned something from this. I'd like to thank Dr. Lynch and Dr. Kinney for the help in putting this together and their mentorship.
Hello, I'm Brad Bemis. I'm an interstitial lung disease pulmonologist at Loyola University Medical Center in Chicago, Illinois. Today I'll be talking about genomic classifiers, specifically about new and emerging data. First, relevant disclosures. I am part of a speakers bureau with Boehringer Ingelheim, where I discuss on-label uses and indications for nintedanib. Our objectives today, we'll review the current diagnostic guidelines for pulmonary fibrosis. We will recognize potential limitations in the diagnostic pathway at individual medical centers. We'll work to understand basic rationale of using this genomic classifier and where you might include it in your workup, and then finally select the appropriate patients that may benefit from testing. So by way of introducing this, we'll use a case. We'll talk about Rick. He's a 65-year-old patient of mine who developed a dry cough 4 years ago. He has developed some exercise limitation related to dyspnea, but just kind of thought it was getting a little bit older. He enjoys woodworking and playing the baritone horn. Doesn't have any birds, but did have a parakeet when he was younger. He has down blankets and down pillows. He's traveled extensively. He doesn't have arthritis or Raynaud's or Sicca syndrome or rashes. He has no muscle weakness or tenderness. He does have GERD, which is controlled with a PPI, and a hiatal hernia in a previous noted Schatzki's ring. There are no family members who have lung diseases, and he didn't notice early graying of his hair. Initial lab evaluation for autoimmune diseases was negative, with the exception of mild elevations in his ESR and CRP, and hypersensitivity pneumonitis panel was sent off and returned negative. Let's take a look at his CT scan. Some selected images here. Okay, and so, we know that radiological patterns of UIP are important, sometimes can give us a diagnosis. And so recognizing them and interpreting them accurately is our first level of diagnosis in many patients who present with ILD, ranging from definite to probable to indeterminate for UIP and alternate diagnosis. I tell my fellows and residents all the time, for definite UIP, we need honeycombing. We need a reticular pattern that's subpleural and basal predominant. We need to have the absence of other features that characterize other diseases. For probable UIP, we lose honeycombing, but we still have a reticular pattern that's peripheral, along with some traction bronchiectasis. For indeterminate UIP, we have subtle reticulation. This is that early UIP pattern that sometimes gets referred to. And then alternate diagnosis, obviously, people who have cysts or ground glass opacities or mosaic attenuation. So Rick came through our clinic and then ultimately was discussed in our multidisciplinary discussion. And the high resolution CT was described as having peripheral subpleural fibrosis, no honeycombs, minimal bronchiectasis, fixed air trapping present in one lobe. And it was characterized as the pattern of indeterminate for UIP. And so we said a diagnosis could not be determined and he needed to move forward with a lung biopsy. So you're familiar with the ATS guidelines for IPF diagnosis. We have our patient come in, we take a good thorough history, get that high resolution CT chest and arrive at our multidisciplinary diagnosis. And then if we don't make a diagnosis, we're given the option of a surgical lung biopsy. But if you don't pay too close of attention, you might miss the fact that there's an asterisk next to that recommendation. That asterisk leads to a recommendation that surgical lung biopsy is not indicated in patients at high risk for intra, peri, or postoperative complications. And this comes from data from the National Inpatient Survey from 2000 to 2011, where they looked at ICD-9 codes and outcomes of patients who had surgical lung biopsies. On average, about 12,000 surgical lung biopsies occur for interstitial lung disease each year. And they carry with it, in that survey at least, an in-hospital mortality of 6.4%. Now, if we recognize that some of those are acute biopsies and we want to select for the people who are coming in from home for those elective operations, there's still nearing a 2% mortality with that operation. Increasing mortality can be seen with male gender, increasing age, higher comorbidity scores, or an open versus a video-assisted thoracoscopic surgery. And so there's a lot of limitations to that diagnostic pathway. Number one, you may not have a thoracic trained radiologist at your institution. Radiologists have some agreement with each other. Thoracic radiologists may be a little bit more correlated with agreement than general radiologists at recognizing the pattern of ILD. You may not have an access to a multidisciplinary discussion or a multidisciplinary team and choose to meet piecemeal, and maybe you don't have that ability to have a robust group discussion about each individual patient. When we analyzed our experiences at Loyola, we looked at 164 patients, consecutive patients that were reviewed at our multidisciplinary discussion. And the radiology read changed frequently, up to 28% in those ultimately diagnosed with UIP pattern fibrosis and 37% in those with non-UIP pattern fibrosis. And we know that radiology is our first line of being able to make diagnosis. So sometimes if somebody has a definite UIP pattern, we're able to say that that person may have a diagnosis of IPF if they have no other known cause. But we need to understand what the other patterns or what predictive value they do have. So Jonathan Chung in 2015 published a review of multiple multi-center studies in patients who had known clinical findings, imaging, genetics, and pathology that were available. Of those that had a probable UIP imaging pattern, 82% had UIP on histopathology. Of those with an indeterminate for UIP imaging pattern, only 54% had UIP on histopathology. In another important study, Brownell published in 2017 two cohorts that looked at pretest probability of that possible UIP diagnosis. The derivation cohort took place at University of California, San Francisco, and the validation cohort took place at Mayo Clinic in Rochester, Minnesota. You can see that in the patients, all of these patients had possible UIP pattern fibrosis on high resolution CT. In the San Francisco population, there was a much lower rate of IPF that was ultimately made after biopsy and clinical diagnosis compared with the validation cohort where 97% of people were diagnosed with IPF. So pretest probability makes a difference. And so in order to better assess those radiological patterns and have more diagnostic confidence, the genomic classifier was invented and produced in order to help us make diagnoses more easily without having to go through a surgical lung biopsy. So the main tool we have is called Envisia, produced by Veracyte. And what they've done is created a tool that they tune with transbronchial biopsies, taking 3 to 5 biopsies from the upper and lower lobes, taking those biopsies and processing them with an RNA-seq tool that identified an expression signature, and then allowed a machine learning algorithm to design that tool, specifically designed for high specificity. And what we found was the expression signatures that were represented in UIP pattern fibrosis were those of predominant extracellular matrix or cell migration, versus those overrepresented in not UIP were immune type of pathways, so immune response, systemic lupus erythematosus, or asthma. And this tool was validated in a couple of different cohorts called the BRAVE cohort. And so patients, Ganesh Raghu in 2019 published the first study of 49 patients that had this genomic classifier used and compared against histopathology with either VATS, cryobiopsy, or transbronchial biopsy. And the tool was able to achieve a specificity of 88%, a sensitivity of 70%, at identifying UIP that was ultimately confirmed on the histopathology. In a second study, a somewhat bigger study by Luca Ricaldi in the Blue Journal earlier this year, 96 patients had the same histopathological procedures done, and the same tool was validated, and again showed a high specificity that the tool could produce. And if we combine cohorts, we see on the app that I have for my phone, the combined specificity and sensitivity of the Envisia results. So 91% specificity and 63% sensitivity. And so if we use some statistical tools and we calculate a positive likelihood ratio, that positive likelihood ratio ends up being around 7. If we take those pretest probabilities that we learned from Jonathan Chung's paper and we apply that positive likelihood ratio, we can see that in the presence of a positive UIP finding on a genomic classifier, we increase the post-test probability from 83% to 97% in a patient with probable UIP. And in a patient with indeterminate UIP pattern, increase the pretest to post-test probability from 54% to 89% that patient would actually have histopathological findings confirmed as UIP. And we see that Luca Ricaldi in the Blue Journal also found the same thing. So among 53 cases with histopathological diagnosis of UIP, only 18 were identified to have definite or probable UIP before that biopsy was taken, so only 33%. However, when we added in genomic classifier, 24 additional patients were identified to have UIP, increasing to 79%. And so those 24 patients, maybe we've added and augmented the radiological pattern recognition, saving them a surgical lung biopsy that could have been avoided, and perhaps making a quicker diagnosis, getting them onto therapy sooner. We know UIP is not a diagnosis, but it can tell us a lot about prognosis as well. You see 2 examples of Kaplan-Meier curves here. The first one on the left is of patients with various radiological patterns of fibrosis with a history of rheumatoid arthritis. And we see that UIP carries with it the same poor prognosis that we often associate with IPF, about a 50% 3 to 5 year survival. In Tomasetti's paper in 2017, looking at idiopathic pneumonia with autoimmune features, those with UIP pattern fibrosis mirrored the Kaplan-Meier curve of IPF patients. We see in Ganesh Ragu's first BRAVE cohort paper that a lot of these patients had patterns, radiological patterns that weren't necessarily consistent with IPF. They had hypersensitivity pneumonitis or NSIP as possible patterns that ultimately the pathology identified as being UIP. So not only can we use the genomic classifier to augment our radiological interpretation, we can actually use it as an extra tool in a multidisciplinary discussion. Lisa Lancaster had a publication at ATS this year where 61 patients were evaluated with suspected ILD. They had a multidisciplinary group review their clinical information and high-resolution CT chest. The genomic classifier and then histopathology were subsequently added. Of the patients, high resolution alone was able to show not UIP in 50 of the 61 patients. When the MDD reviewed the clinical information as well as the high resolution CT, 31 patients were unclassifiable. With the genomic classifier alone, 23 patients were able to be classified as UIP, and ultimately 12 more with histopathology. So those 23 patients, again, may have been able to be saved a surgical lung biopsy in that high mortality risk. And a preliminary look at the Catalyst study, which was produced by Veracyte, they reviewed 98 patients from that same BRAVE cohort and gave two multidisciplinary teams different sets of information. They both had access to clinical information as well as high resolution CTs. One group, version A, had histopathology available, and group B just had the genomic classifier available. They were asked to identify IPF versus not IPF. You can see that the results overlap quite nicely. So with the Envisia alone, IPF was diagnosed in 13 patients. When the histopathology was able to be reviewed, 11 of those patients were classified as IPF. Okay, and you can see the overall CAPA was 7.73, and overall agreement was 92%. In another real-world example from Tulane, published in 2020 in Chest, a very similar type of study was performed, where we had two separate multidisciplinary discussions, both with clinical and radiological data, and then sequentially added cryobiopsy or genomic classifier results. And we can see that in each of these steps, both the radiology and clinical interpretation, we had a lower diagnostic confidence. And then providing histopathology, we're able to increase that from 13% to 46% diagnostic confidence, which ultimately went up to 75% after adding the genomic classifier. And so we can identify now maybe a new way to make a diagnosis of interstitial lung disease and of IPF for that matter. So in each of our different groups of radiological patterns of fibrosis, we can find a place for this genomic classifier tool. The most useful, I think, is in the indeterminate for UIP classification, where if we have a patient that has an indeterminate pattern of fibrosis, we obviously look for clinical context, but then we can add in a BAL, a transbronchial biopsy, and use of the genomic classifier to then rule in a UIP pattern. Okay, and we rule that UIP pattern in the absence of other findings, we would make that diagnosis of IPF. You may also use this in a probable UIP pattern of fibrosis where you have clinical context that suggests some other etiology. So maybe you have somebody who has a lot of birds at home or has a lot of mold damage and you suspect hypersensitivity pneumonitis. You may use that BAL and transbronchial biopsy and genomic classifier to get more information about that patient and their pattern of fibrosis. And so in our case, going back to the beginning, Rick had his Envisia result come back as positive for UIP. Ultimately, we went back to the multidisciplinary team and revealed this new piece of information. And with that piece of information, in the absence of other known causes of fibrosis, we ultimately made a diagnosis of idiopathic pulmonary fibrosis, and he was able to get started on treatment with nintedanib 150 milligrams twice daily. So hopefully this clarifies a little bit of the goals that we set out to accomplish. The use of the genomic classifier in your standard workup, where that could work for you if you have a robust multidisciplinary team, or whether you don't have that capability but need to augment your diagnostic tools that you already have at your disposal. thank you for everybody from the Loyal ILD team and for Verisight for sharing some slides with me as well. I was preparing for the talk, and thank you, and I look forward to your questions.
Good afternoon, and welcome back. My name is Meryl Kreider, and I'm from the University of Pennsylvania, where I'm the director of the ILD program, and I'm here to walk you through an MDD. I'm very fortunate to have several experts who come to me from across the country to help be part of my panel. With me today, I have Dr. Jonathan Chung from the University of Chicago, who is going to be our expert radiologist, and you just heard him talk a couple minutes ago. We also have Dr. Lita Herreri, who is our pathologist, Dr. Erica Ferrand, who's from the UCSF, and Dr. Carrie Aronson from Cornell. We're going to walk our way through two cases, and what I hope we'll do is try and simulate to some degree an MDD of two cases that I brought with me. And what I'm really hope we'll do is talk a little bit about these cases and have a good discussion. I'm also going to ask my panel some questions that I hope will be questions that you think of as we walk through them, so that you get a little sense of the kinds of questions and the thoughts that we have as we evaluate some cases from a typical ILD program. I'll tell you, these aren't, your random ILD cases, obviously. We brought them because they have both good pathology and good radiology, and they raise interesting questions. So without further ado, here we go. All right, case one. Case one is a 62-year-old gentleman who developed dyspnea with exertion starting about 3 years ago. He presented with some productive cough and some chest tightness, and really the remainder of the review of systems was unremarkable. This person had no prior pulmonary history, did have a little bit of GERD with some Barrett's, had worked as an EMT, had no pets, and in particular had no birds or bird products. This denied any prior mold damage to the home, was a former smoker, about a 20-pack year, and had quit about 5 years prior to presentation. Interestingly, did have a family history of 2 cousins with pulmonary fibrosis. On presentation, initially had some normal vital signs, but did desaturate with walking in the office. The pulmonary exam was unremarkable without any wheezes or crackles, and the exam was otherwise unremarkable with no stigmata of connective tissue disease. The data on presentation really had normal forced vital capacities, FEV1, and a total lung capacity, and the DLCO was moderately reduced, and he had the following chest CT. And I'm going to ask Dr. Chung to take a look at it.
So first step, whenever we look at these high resolution chest CT scans, is to kind of determine the adequacy of the study. And so this certainly looks like it was performed using a very good technique, clearly thin reconstruction based on the spatial resolution and the detail that I'm seeing here. And it was clearly performed using a high frequency algorithm. So bottom line, a lung algorithm rather than a soft tissue algorithm for CT reconstruction. So bottom line, beautiful HRCT, but really that is the first step. A lot of times we get these CTs from other places, maybe not performed on site. And so they're variable quality. Some are amazing, exquisite. It's embarrassing how nice they are. And other times they leave a little bit, to be desired, unfortunately. And in those cases, it probably makes sense to try to acquire a diagnostic HRCT, but this is clearly diagnostic. So what do we see here? We see mild reticulation. So a little bit in the peripheral portion of lungs, both in the upper aspect of lungs, mid-lung zones, as well as the lung bases. And a little bit subtle, but as you go from upper to mid to lower aspect of lungs, it clearly looks like there is a basilar predominance. There is a trend toward increasing reticulation as we go down. And very subtle, but there are some areas of mild traction bronchiolitis, particularly within the lower lobes. There are no other features here that suggest an alternative diagnostic category. So there's no significant mosaic attenuation. I don't see much nodularity here.
It's clearly peripheral basa predominant, no consolidation. So this to me looks like a good look for probable UIP. I don't see any evidence of definite subpleural honeycombing on these images, though when it's this mild, if there is honeycombing, very often it's very, very subtle and can be difficult to see. So overall, from an HRCT standpoint, I would say this is a probable UIP pattern.
Jonathan, can I ask you a question? I think one of the most challenging things is this category of indeterminate. And I think it's used a little bit freely, and I don't know that I understand it. And I think it's partly because there's a difference between the Fleischner and the ETS. Can you help me understand what indeterminate is and if this might be an indeterminate?
So I can see how someone might call this an indeterminate for UIP pattern. So depending on whether you're using Fleischner or the multi-society guidelines, in spirit, I think they're saying the same thing. The indeterminate for UIP category is essentially pulmonary fibrosis patterns that are either too mild or too weird for you to confidently say it's something else. It's confidently say UIP, probable UIP, or alternative diagnostic category. And so now that, in the 2000s, using the 2011 guidelines, so way back, right before the new guidelines came out, we didn't have an area for these sort of hard cases or mild cases. And now we do. It's the indeterminate for UIP category. And so the problem is no one really knows what to do with that category at this point. Obviously, I think most people still treat it as like an alternative diagnostic category, but we need to gather more data to figure out what's the diagnostic outcomes, maybe even therapy ramifications of that specific pattern. But I can see, so this is pretty mild. So I can see someone calling this indeterminate for UIP, but just based on the look of it, I feel good for this being probable UIP. So whether you want to call this probable UIP or indeterminate for UIP, I could see, and you were, let's say you were to survey 100 chest radiologists at academic centers, I think you could get a decent breakdown of people choosing probable UIP and indeterminate for UIP. But for me, it feels like probable UIP, just mild.
All right. And so I will tell you that this was read as indeterminate at the time. And this person was seen several times over the next year with progressive cough. They were trialed on inhalers, NAC, and prednisone. This was also a couple of years ago. And was noted to have progression with decreasing FVC and a TLC. And the chest CT was also noted to be progressive, and I'll show you those images shortly. They were given a presumptive diagnosis of idiopathic pulmonary fibrosis and started on pirfenidone. And at that time, additional blood work was sent, and that includes an ACE level that was elevated, and they had several positive precipitants on a hypersensitivity panel, and they were referred for VATS. And let's just look at the CT before we go on to the biopsy.
Wow, so this is actually very interesting, isn't it? So clearly progressed over time. There's more reticulation, but there's more ground glass as well, some patchy ground glass abnormality. The distribution now, before I thought it was basal predominant, I'm not sure. I'm not sure anymore. It sort of evolved into, now it'd be kind of a more indeterminate pattern for me because I don't know what to do with it. It's a very, very odd pattern. In the axial and zonal plane, if all I had was this CT, because of the ground glass opacity, because of sort of the more diffuse distribution, I would start thinking about hypersensitivity pneumonitis at this point, but not confidently. Using the UIP classifications, I wouldn't immediately go to alternative diagnosis here. This is now actually good for indeterminate for UIP, more so than the original CT scan in my mind. And so this is a very interesting evolution.
Just sorry for the fuzziness. I just wanted to show the coronal to sort of help you out a little bit with the zonal distribution as well.
Nah, this doesn't help me. it's still very confusing. Still very confusing. No, it's just it's a very confusing pattern.
All right, Lita, can you help us with the walk through the pathology?
Yeah, sure. So the pathology on this case was really quite interesting, and I think is a good example of why pathologists need to make sure they look for all the things and know the things to look for. So at low power, if we look at the image that's on the right-hand side, what you can see is that there's a nodule of fibrosis there with some cystic structures that look like they're probably consistent with honeycombing on the top slide. And on the bottom slide, you can see a similar picture where there's some subpleural fibrosis with more cystic honeycombing and some interstitial thickening within the alveolar walls away from more of the dense fibrosis. It'll be good for us to take a closer look. So if we could take a look at the next slide. If we look closer at those cystic structures, they are indeed microscopic honeycombing. They're submillimeter in diameter, which is why they're probably not visible on the HRCT at this time. They're embedded within dense fibrosis that's immediately subjacent to the pleura. And then if you look at the bottom right-hand image, you can see there's a fibroblastic focus. There's also some spatial heterogeneity as well, where you can see the dense fibrosis in the top left-hand image. Then if you move just a bit right in that image, you can see that there's some preserved alveolar parenchyma. So based on these images, at least from what I've seen so far, this ticks all of the boxes we'd be looking for UIP. So destructive subpleural fibrosis, honeycomb cysts embedded, and spatial and temporal heterogeneity. Now, as pathologists, it's our job to make sure that we look for any aberrant features similar to what we look for in radiology, which could include identifying a more prominent airway-centered fibrosis, the presence of granulomas, the presence of more conspicuous lymphoid infiltrate, especially lymphoid aggregates. And so we'll spend our time looking for that as well. Next slide. And so in that search, what we started to notice was here in this image, if you focus on the center of the image, this is an airway with an immediately adjacent vessel paired to it. So this is a bronchovascular bundle. And what you have immediately surrounding that is an airway-centered fibrosis with a little bit of some loose inflammatory aggregates that even from this low power, I start to get suspicious might be some granulomatous histiocytic inflammation. So this in itself is starting to become suspicious about as being basically a background UIP pattern that does have aberrant features that are going to make me start thinking about things that are not idiopathic in etiology. Next slide. Here we can see in other areas, there's some more reminiscent abnormality towards the center of the top of the image. You can see a nodule of fibrosis, which you don't typically see a nodular aspect like that in a traditional pure UIP pattern. This fibrosis is not an extension from the subpleura moving down. It's sort of a bit more isolated and surrounded by more of an interstitial fibrosis pattern where there's alveolar wall thickening. So again, a bit unusual, but none of these so far are enough to really push me that, yes, I'm absolutely confident this is a secondary UIP or a mixed pattern. But I'm now, my spidey sense is sort of tingling and I'm looking very, very carefully for additional aberrant features. Next slide. And lo and behold, with enough searching, we finally find them. So away from the areas of dense fibrosis, we can see aggregates of peribronchiolar loose histiocytic inflammation, or what we call granulomatous inflammation. This is indicative of an airway-based inhalational exposure. And so the things to think about when we see these features on the background of a fibrotic ILD are usually top in our differential is hypersensitivity pneumonitis. It also can represent other inhalational exposures such as aspiration superimposed on the fibrotic ILD can present with a picture like this. Occasionally, some connective tissue diseases can present in this way as well, especially things like Scleroderma, where if you have an esophageal dysmotility, you can have an aspiration event, or you can have other exposures that can lead to granulomatous inflammation as well. So now seeing these, this basically takes this based on the guidelines out of a pure UIP pattern because we have evidence of airway-centered components and peribronchial granulomatous inflammation. And so for me, this would put it in basically the indeterminate category because I'm thinking that this is a UIP, a predominant UIP pattern of secondary etiology that's likely HP or connective tissue disease, potentially superimposed aspiration. I think that's all we have. Yep.
All right. So now we have a high-res CT that is indeterminate and a pathology that is somewhat indeterminate. So I'm going to turn to you, Erica, and ask you, we have this elevated ACE and a positive precipitans for a couple of things, and now maybe some granulomas and a CT that is not a slam dunk for really anything. What do you make of this gamesh?
It's a little bit of a mess, which is, I imagine, why you chose this case. I think I would start by saying I can talk about the precipitants panel to begin with, which is something that I don't use very regularly. I actually don't order at all. I'll look at it if it's sent, as part of a referral, but often, we all know that we're exposed to things all the time, and the majority of us do not develop lung disease from it. And so the precipitants panel to me often raises more sort of, what is the term I'm looking for, but sends me down a rabbit hole more than directing me towards an answer. I do think it's helpful now that chronic HP is in the differential to really kind of explore a really good HP checklist, which is giving a really thorough deep dive into the home and work environment to figure out if there are exposures. But we also know that often we're unable to find an exposure, and so have to make a diagnosis without it. I think, and then similarly with the ACE level, when we have these sort of one-off markers, I think it's tempting to put a lot of stake into them, but it's important to kind of frame them within the overall picture. And overall, we have a patient who's had largely progression of a fibrotic process over their 18-month period, but right now in their most recent CT scan has evidence of active inflammation. And Lita, did you mention, I know you said you saw areas of granulomas, were there other evidence of active inflammation on that biopsy, which would be interesting to coordinate?
No, it was all mostly that granulomatous inflammation. So there wasn't like a lot of lymphoid infiltrate or aggregate or anything along those lines.
Right. Okay. That's helpful, I think, when we start to think about how to treat this patient. But I do think we have someone who, regardless of what we think sort of triggered or started the process, is certainly following what looks like a progressive fibrotic phenotype. And the question is really how concerned we are about the inflammation that we see on the CT scan, and how much does that really weigh us in terms of management up front.
Carrie, how about at your place? Are you guys using the precipitants, and is the precipitant enough to push you toward calling this chronic hypersensitivity pneumonitis?
Yeah, so most people at our institution are sending it, but I often, sort of as Erica said, I find it not helpful. It's not very sensitive or specific, and oftentimes I think it causes a lot of angst amongst patients about, these findings in their serum that may not have any sort of clinical value whatsoever. And even when we have had really helpful home inspections, oftentimes what we find in the home it's not concordant with what the serum precipitants are. So I do think that it can sometimes add more confusion, but it is on our standard ILD panel that is sent really on anybody that gets referred. But how helpful it is all the time, I'm not so sure. And I oftentimes have to find myself explaining that to people, well, we send it, but it's not very helpful. And so it can definitely, create a challenge. I think that the history, also, as Erica said, is really, really the most important. And if there really is an exposure that we can identify, if someone's able to have their home or their occupation adequately inspected, and have a really good history, that definitely weighs a lot more into my clinical decision than the serologies would.
And so, Jonathan, I think this comes back to you, and we say we have a pathology that is probably most consistent with HP. We have a panel that's positive, but no obvious etiology, which, as we all know from studies, is pretty common. For the new guidelines, if we have a CT that is consistent, we can think about whether this is diagnostic or not, but we can never have more than moderate certainty.
Yeah, so if we're going down the HP pathway with fibrosis, we clearly have fibrosis. We have sort of the three tiers. We have typical, compatible with, and indeterminate for. And so, no guidelines are perfect. And so these HP guidelines certainly are not perfect either. This is not a typical HP pattern at any stretch of the imagination. It just isn't. And so really we're dealing with either compatible or indeterminate for UIP. And I think that so we have more of a diffuse zonal distribution, but not a lot of manifestations of air trapping. And really to invoke the compatible with HP pattern on CT, you need that air trapping. I don't confidently see that on this CT scan. So if I had to, I would put it in the indeterminate for HP category, but the ground glass opacity, the kind of diffuse axial and craniocaudal distribution makes me feel like it's got HP in it. So it's like, if there were a category in between, like indeterminate for indeterminate HP, I don't know, something like that, in between compatible with and indeterminate for HP, that's where I would put it, because that's probably what it represents in terms of imaging.
Jonathan, I think you need to write an editorial and suggest that that be added as a category, please. If you would please do that, I would appreciate it so much.
I'll do it. You can be my co-author.
I would be happy to do that. Just to have Dr. Ragu respond back to it, I would be more than pleased to do it. I did have a question, because one of the things I thought about in looking at the radiology and the path is that initially it was basilar predominant, and then later this ground glass came up, which to me, in my experience, is a bit unusual to have a UIP smelling pattern then turn into a more classical HP, especially if we're under the assumption that, you know, patients initially present with a non-fibrotic HP, which then transitions into a fibrotic HP. You would expect there'd be some mosaic air trapping, you know, at the earlier time point. Makes me start to wonder more about like aspirational events. Aspirational events, is that a word? Aspiration events. Is it worth like looking at like, you know, dysmotility studies or doing a barium swallow to see if maybe this patient is aspirating, and that's what this ground glass and granulomas are all about?
I think that's a really great comment. We talk about this a lot in our MDDs, and we oftentimes really entertain doing that, especially if the CT scan sort of pattern fits with that. Because certainly, you know, with the ground glass in those areas that then are sort of those areas of fibrosis, and I don't know what you think, Jonathan, but, you know, oftentimes that's kind of thrown into the differential as well. And so we definitely do aggressively ask those questions. And, you know, I have sent patients for those studies to sort of look into that further as a potential etiology.
Yeah, I mean, on imaging, they talk about, you know, we think about sarcoid or tuberculosis. That's called like the great mimicker. I swear though, you know, aspiration really is the real great mimicker. It can look like anything. It can look like consolidation, ground glass opacity, reticulation. Like I've been fooled before where I've only had one phenotype, like one time point rather, and it turned out just to all be aspiration. But gosh, it looked exactly like an interstitial lung disease. So never hurts to check for aspiration.
And it's such a great point. It's such a great point, Lita, because as you pointed out on the path, we don't see a correlate for that inflammation, right? So it really suggests that there could be a secondary cause there that we should evaluate. And you know, also not to anchor too much on the presence of inflammation there and really lose sight of the fact that underneath all of that, what we see is mostly progression of a fibrotic disease.
I think the point too that was brought up about the sort of the inflammatory findings being a later finding rather than an earlier finding, you know, one of the things sort of at the end of all of this is trying to decide, well, what are you going to actually do for the patient? And, you know, making the determination of treating with something, and I know we'll probably talk about this, that's, you know, going down the antifibrotic route versus thinking, well, should I be thinking, you know, should I be thinking about immunosuppression route? Because, you know, is there evidence of inflammation? Would this person respond to that, potentially feel better with that? But could it potentially harm them? I think that's one of the really difficult things, especially I think with this case, makes this case very difficult, especially when you have to get to that decision point.
Well, I'm going to cut off this discussion a little bit because I do want to get to our second case, and we are halfway through our time. I'm going to ask you guys to do the hard thing, which is what we would do at the end of an MDD, which is to say, can we give this person a tentative diagnosis and then decide what we would do next? Remembering that they are already on pirfenidone. So would you call this a hypersensitivity with a moderate or low confidence, or would you still prefer to call this unclassifiable? I need votes.
Someone else go first.
I think I would, honestly, I think I would call unclassifiable until we do the aspiration workup. And if that came back negative, then I think I would be willing to put my money down on HP. But still, I still think the management in that case would probably be more continuing antifibrotic than starting anti-inflammatory, just given the progression of disease that we see there. But that's a hard call. You know, that's a really hard call.
I agree. I agree with all of that. I think that the aspiration workup is definitely indicated here, just given sort of the pattern of CT over time. And I think that there's clearly some supporting evidence of HP. So if we didn't find that, a fibrotic HP would probably be sort of the diagnosis that I would give, but then thinking about how to treat it, I think would be another discussion and potentially actually a difficult decision, especially because our patient's already on pirfenidone, which we haven't necessarily studied, very, in a large trial in that population. But, I think it would be difficult.
And one last plug, I think that we haven't talked about, but I would just say that this patient deserves an echo. They had an isolated reduced DLCO from the beginning, even though the rest of their lung volumes were normal, and desaturated from the beginning, even when they had early disease. To me, that's always sort of a red flag to, one, think about connective tissue diseases where there's more risk for pulmonary hypertension, but even outside of that, in our patients with chronic HP or IPF, always a reason to get an echo. So.
Yeah, agreed. I was thinking exactly the same thing, especially because the findings on CT just didn't necessarily fit with that reduction in DLCO, and certainly the rest of the PFTs being within the normal range. So I thought exactly the same thing. That's a really good point.
Great point. All right, this case 2 is a 52-year-old woman who presented recently to the ED with shortness of breath. She reports symptoms started about a month prior after exposure to when they were doing some mosquito spraying in her neighborhood. Almost immediately, she began to develop shortness of breath and cough and chest tightness. Her primary care doctor gave her 12 days of steroids without any improvement. She returned to her primary care doctor, who ordered imaging and then referred her to the emergency room. In the ED, she was tested for COVID 3 different times, and then given azithromycin and ceftriaxone for community-acquired pneumonia, and then admitted. When there was no improvement after 3 days, Pulmonary was consulted. Her past medical history is significant for some chronic low back pain, hypertension, chronic sinusitis, diabetes, and asthma, which was an adult diagnosis. And her flares were typically after sinus infections, and she gets 1 to 2 prednisone tapers a year. Her only medications on admission were aspirin and benzapril hydrochlorothiazide. She's a never smoker. She drinks 2 drinks a week. She has no drugs. She has a pet dog. She has no birds or down. She has no mold, water damage, humidifier, or hot tub. She has, interestingly, 2 sisters with sarcoidosis. Her review of symptoms was notable for burning in her legs with intermittent lower extremity cramping for the last year. She had no rash, Raynaud's, oral ulcers, dry eyes, dry mouth, etc. Her physical exam was remarkable for the fact that she was 97% on 3 liters, but desaturated to 79% on room air while walking 50 feet. She had diffuse crackles, no wheezes, and an otherwise normal exam. As noted out prior, her COVID was negative ×3. Her more broad RVP was negative. She had a negative urinella Legionella antigen. I can't speak. And her sputum was saliva. Her CBC, she had a white count of 12.2 with 79% segs and 1.6% EOs. Her pro-BNP was less than 5. Her LFTs were unremarkable. And this was her CT. Jonathan?
So, yeah, these are hard. When you have diffuse white stuff in the lungs, ground glass opacity with some mild consolidation, in today, like walking into the ED like today, in this era, like 2020, 2021, the first thing out of my mouth should be COVID, and I should be saying it 2 or 3 times. So I understand why she got tested 3 times for COVID, as is everyone else who's watching this, right? We are living in the era of COVID. So that would have been sort of my main concern. Is this some sort of atypical infection? And then the next thing, once we've excluded that, would be, well, is it some other type of infection, right? Just given the fact that it's white stuff in the lungs, it's the diffuse process, that's something else to consider. The classic differential diagnosis for diffuse opacity in the lungs include things like pulmonary edema, pulmonary hemorrhage, obviously massive aspiration, things like that, right? And so that's the first thing to really consider, are sort of more of those acute things. So it would be nice if we can somehow search back into like the patient's clinical record, maybe at other hospitals, to see if maybe the patient had any other imaging, because the differential diagnosis for this pattern, whether it's a recurrent pattern versus a one-time deal, is very, very different, right? So I think most radiologists in interpreting this scan without comparison would just assume that it's some sort of atypical infection or some sort of lung injury, quote unquote lung injury, some sort of acute event, move on and just think that the patient would be further evaluated with bronchoscopy. If it's a chronic process, however, we start thinking about different things. Subacute to chronic process, we have that exposure from 1 month ago where symptoms kind of started. So if we're kind of going that more chronic diffuse lung disease pathway, we start thinking about things like organizing pneumonia, obviously eosinophilic pneumonia as well, and obviously the subsets of eosinophilic pneumonia like the Church-Strauss syndrome. Organized pneumonia would be also another consideration given the basilar predominance here. And then some other odd things you can kind of think about, but probably aren't the right answer, like desquamative interstitial pneumonitis. Unfortunately, based on the imaging, there's nothing specific here. What I can say is if we're going to go down sort of the UIP pathway and sort of use that framework, this would certainly be an alternative diagnostic category. This is not UIP. I don't even know if there's real fibrosis on these images.
Perfect. Thank you. All right. She did get a bronchoscopy because everybody was, of course, very concerned about infection, and we did a transbronchial biopsy at the same time.
Great. So these are much smaller than the surgical lung biopsies we got before, of course, being a transbronchial biopsy. However, I think we have picked up some abnormality, and I think this was a good approach given how much airway-centric abnormality there was on the CT. So I think that it is likely reflective of what we saw on the CT. And so interestingly here, you can see a couple of things. First, this looks like it's a mixed fibroinflammatory process. Here on the bottom right image within the alveolar wall space, you can see that there's an increase in pink and there's scattered blue. And so it's a crude way to basically say there's more collagen and there's some lymphocytes hanging out in that same space. Just in this top right corner, you wonder if there's, directions. Top left corner of the right-hand side image, you wonder if there's a little bit of increased inflammation, but it's a bit cut off, so it's hard to tell. The top left image basically shows similar types of things where you can see that there's some increased collagen, increased inflammation, but overall, thus far on this image, more non-specific findings. But I think we have another picture on the next slide. Yes, and so here we have much larger biopsies. Honestly, these almost look cryobiopsy sized. Whoever did this transbronch, kudos to them for getting such great tissue. And so here you can actually see something that looks very reminiscent of sort of the more consolidative pattern that we were seeing on the CT, where you can see that again, there's both mixed inflammation with fibrosis, but here it's more fibrotic predominant, which is super interesting given that that was difficult to distinguish on the CT. And so overall, this looks like likely my best top diagnosis is that I would favor, given the radiology and what I'm seeing on path, is that this is probably a fibrosing chronic organizing pneumonia. However, we'd have to make sure that we rule out other etiologies because we know organizing pneumonia can show up in all sorts of things. So narrowing down a specific etiology based on this, I think would be challenging, but looks like OP to me.
All right. And then she was sent, a bunch of serologies were sent in. Interestingly, her Rho 52 was elevated and her Jo 1 was markedly elevated. Her ANA was negative. Her CK was normal, and all of her other serologies were unremarkable. So what do people think?
Now I want to go first.
Okay.
Well, I have help now, right? So so the pathology is consistent with organized pneumonia. Imaging now, I think, is very highly suggestive of organized pneumonia. I'll leave the clinical sort of discussion to you guys, but based on everything that's been discussed, it's I called it alternative diagnostic category, but I had trouble kind of definitively saying what it was. And sort of there are a lot of cases like that where it doesn't look like UIP, but I'm not exactly sure what it is. But that's the beauty of MDD, isn't it? Because you guys come with your data, pathology comes with their data, and then I come with my CT scan, and then we just sit there and talk about it and discuss what the best diagnosis is for a particular patient. And so now that I have all the data in front of me, I can be more specific. And I think, yeah, it's good for organizing pneumonia. And I'll leave it at that.
All right, Carrie, what do you think?
Yeah, so I mean, the serologies are definitely, helpful in leading you towards, an underlying connective tissue disease, myositis related, ILD. I don't remember you saying that there were any significant like room review of systems were positive or on a physical exam. Certainly that would make you go back again, I think, and really ask. But sometimes, in that's what I'm thinking. I'm sort of thinking down that line. In that scenario, sometimes you don't necessarily find that, and the lung disease may be the most prominent sort of thing. But I think it would be interesting to go back and sort of ask those questions, in that past, the month prior when you were feeling unwell, what other symptoms or, in the past several years, what other symptoms have you had that maybe were sort of overlooked as something else? And then the other interesting thing is that the patient did receive prednisone for like 12 days. I'm not sure exactly, what the dose was, if they had felt any better. In that scenario, sometimes I would think, would they have felt any better depending on the dose, et cetera? So that's sort of another question I have. But certainly, I'm sort of definitely with those serologies, and certainly we know that definitely myositis-related ILD can look like OP. Sometimes it's talked about that sort of that overlap NSIP OP picture, which I think Jonathan can probably speak about on imaging. So I'm definitely thinking along those lines, and certainly a lot of active inflammation going on the pathology and the imaging as well.
Yeah, and I would add that there's a couple of things from the history that sort of maybe clued us in that this could be a CT-ILD. One, the patient's young, this is a 52-year-old, which is a baby in ILD land. And so certainly just age alone makes me think more about CT-ILD. And then I do think there was some in the review of systems, like a restless leg or some muscle aches or something that sound myalgia-y. So again, would agree with Carrie that we go back and explore that a little bit further. Here, I think the bronch with biopsy was really important, right? Because there were so many other pieces in the history that made us think about eosinophilic pneumonia, and certainly the CT findings, we couldn't distinguish between the two on that alone. But the history of adult onset asthma, there wasn't really any peripheral eosinophilia, but again, the patient had been on prednisone. So this was a case where I think we really did need to have that bronch and a diff and a biopsy to help us know which direction to go in, so we could kind of have an understanding of, although all of those paths lead to immunosuppression, how long what we were talking about in terms of immunosuppressive agents and the length of treatment.
All right, terrific. And I chose this case just to remind us in this day and age that ILD is alive and well in the time of COVID, and that all acute respiratory failure that looks like COVID is not, some of it is still ILD. And I'm going to have us stop here. Although I will tell you that also we should theoretically and in practice actually have a rheumatologist as part of our ILD panel. Unfortunately, we weren't unable to have one with us today. I did have a rheumatologist help me with this young woman who in fact does have an aggressive form of myositis. Unfortunately, these antisynthetase that show up with organizing pneumonia can have very aggressive courses, and she's actually in the ICU right now. She's sort of flared through high doses of steroids and then has had some PEs, so it's been a rough course already. All right, I'm going to wrap up and start by thanking my panel. Thank you guys very much for joining me today. These were some great cases, and I appreciate your expertise. And I'm going to turn it back over now to Dr. Tomek and Dr. Dilling, who's going to wrap up for the afternoon. Thanks to everybody.
All right. Well, that was a great MDD, and all the folks out there watching have maybe a better idea than they had before what goes on at the ILD center or in the MDD meeting to help us discern the consensus diagnosis with the multidisciplinary approach. Great. Thanks everybody for showing us. And before we wrap up the day and the summit, I wanted to make sure everyone out there knows that all of the sessions from today, all of the sessions from the whole week, in fact, are going to be available for review, for watching, for viewing, for 3 months on the platform of the Medscape Live that we've been using all week. And you saw how easy it is to log in, just your email address. So you can use these slides with your team. You can watch them as groups. You can learn together with your nurses and physicians and PAs and NPs and respiratory therapists. Get together in groups and watch these videos and learn from them together. And it's a great teamwork exercise. And so for 3 months, they'll be available that way. And actually 3 months from now, they're going to be available without a need for registration for the meeting through the Pulmonary Fibrosis Foundation website on the YouTube page that they have. So, these will be there for watching for eternity. So all the people in the session today, you're going to be stuck on the internet forever, but that's a good thing. So I'd like to maybe thank my co-chair today, Rade Tomic, as well as our third co-chair for the whole meeting, Mary Streck. I want to thank all of the staff of the Pulmonary Fibrosis Foundation. I want to thank all of our speakers and moderators from the whole week. Thank you to the sponsors who helped make all this come together, and the Medscape Live people who helped it come alive on the internet. And maybe I'll hand the next set of comments over to Dr. Tomic to wrap up the week's summit. So thanks again.
Thank you, everybody. It was a really enjoyable experience. The summit went great. Thank you for the organizer. Thank you for the PFF for inviting us to chair the meeting and to inviting all of you to be part of this. I think it was a great experience for our patients and all of us. I will finish. I'll be short. I just want to say, and I hope that I will see you all in Orlando in 2 years. And hopefully it will be in person, as I think all of us hopes. So thank you, everybody. It was a great summit, and looking forward to seeing you in Orlando in 2 years. Thank you all. Bye-bye.